All right, good morning and welcome everyone. Really excited to have you out here for our Wisconsin Clinical Lab Network regional meeting. We've got a fun theme today. Before I jump in, I do want to thank Erin Bowles for putting all of this together. She makes it look easy, and I know it's not. So please everyone, a round of applause for Erin and all that she does for the Clinical Lab Network. All right, so I'm going to talk about data today. We try to do this every year, give you an update on what's circulating, what we're finding from all of our data. I'm going to start by a little bit of background on what's new in our surveillance requests and go through the booklet and why we ask for this data, what we use this data for, and then we'll go into the data itself, kind of a deep dive, lots of graphs as we go through a whole bunch of pathogens at a very high level. Now, a lot of these topics are going to be covered in more depth throughout the day by other speakers. I'll try to point out where that's going to be. So public health surveillance data comes from a lot of different requirements and sources, but at the very highest level, there are nationally notifiable diseases. These are things required by national, dictated by national statutes, and it's a long list of diseases and organisms in there. And below that is the Wisconsin reportable diseases, and these are the things required by state statutes. Now, fortunately, our Department of Health is really good, and everything on the national notifiable list is also on the state reportable list, but there's some additional things state-specific that they're also looking for within that. Now, the state statutes are pretty strict. If you're not compliant with submitting data for the reportable diseases, there is risk for fines and even imprisonment. Now, because this is government and changing things in government can sometimes be very, very slow, we've built on additional surveillance measures through the Wisconsin State Laboratory of Hygiene. This is, we don't imprison you if you don't report, but it has that flexibility of going really quickly. We can ask for something new and emerging right away. We don't have to wait through full government approvals to ask for this. And it also helps us to collect residual specimens. We can do additional testing for public health purposes. We'll talk about more as well. This makes us agile and capable to respond to things like COVID that first came out. All of our early COVID data came from this clinical lab network, supporting us, sending us data before it was required by state statutes. So thank you for all that you do to help keep our surveillance system strong and agile. So the Wisconsin State Laboratory of Hygiene does a lot of testing. We do some clinical reference lab testing, but a large bulk of what we do is surveillance testing, monitoring, further evaluating different things. And this is largely funded through CDC. We're in a reference lab for them, an extension of the CDC for a lot of different programs. It's a very large alphabet soup, you can see here, but it's things like antimicrobial resistance, enteric pathogens, invasive bacterial, vector-borne, vaccine preventable, National Influenza Reference Center, waterborne diseases. There's a whole bunch. Not all of them have pretty picture graphs here, but I threw up the ones that I did have. And so to support this national surveillance and this local surveillance, we put out a booklet every year called our lab-based surveillance plan. And our newest version, you can see the picture here, has already been sent out to all clinical labs in the state. So if you haven't had a chance to see this, we'll also have some of these booklets on our front desk where you signed in earlier today if you want to take a closer look. So what's in this book? It covers a lot of different things we're going to talk about this morning. How surveillance data is used and why it's important, what data is requested and how to report, isolate and submission requests and how to submit them, and surveillance data from the past year. So you can see exactly what's coming out from what you've been submitting. So we've had some updates this past year. Our lead virologist, Erica Hansen's done an amazing job revamping this book, bringing it up to date and kind of expanding its utility here. So it's got a different look than we've seen in the past. She put some figures and pictures in there to make it a little nicer, but overall the changes include general broadening of the language. In the past it was very virus specific. We're working to make this more comprehensive to all the different types of pathogens, to be more inclusive. And each section we try to include more details on why we're doing this, the purpose of the program, how this data is being used, and why it's so important to submit this. Another major change we've had here is taking out the data reporting table. So we've learned from your feedback, which we want to get more of that today, that the people reporting the data are not always the same as the people who are submitting the samples. So we've separated these out into separate tables instead of having them all mushed together in one. Made one very easy to read data reporting table. Now with this data reporting table, we've also removed quite a few things this year that we found we weren't following up with, we weren't using as much, or we had other ways of getting the same data. The important part here is we respect your time, and we're not going to ask for something if we're not going to use it. So some of the changes, just to summarize, some things have been consolidated. So now it's just general Vibrio instead of specifically calling out the different Vibrios. Shigella and EIEC are now combined into one group. And we've dropped quite a few things. Now, as I mentioned, this is because we either don't need the data or we have other ways of using it. We weren't using it for anything meaningful at the time. And we've not asked for any new data in this booklet. Once again, we respect your time and we're only going to ask for what we need. Some other updates for the booklet here are some changes that are happening within the State Laboratory of Hygiene. So when the pandemic first started, we were the first lab to have COVID testing, and it was really our honor to be able to offer what we could and support COVID testing. But what we really love is that all of you have that testing capacity now. And it's really important for us to find our role in the public health realm, that we support testing that you're not able to do yourself. We want to have testing close to the patient for fast turnaround time. And so our SARS-CoV-2 testing has now shifted entirely for public health purposes. So we're asking for residual samples, residual positives in your laboratory to do sequencing on to evaluate for strains that are circulating, new and emerging strains that might be coming out. And so for this reason, we're down to just surveillance testing for SARS-CoV-2. We've gotten rid of our old SARS-CoV-2 submission form and combined it with our other respiratory form, and a couple of these new updated rec forms were also included in the booklet when we sent it out. I did want to put a little note at the bottom. We are continuing to see a lot of mergers and changes in hospital systems, and some common questions that have come up are, what should you report if you're merging with another system? If now most of your testing is going to a core lab, do you still need to report that data? And what our overall theme is, if you do testing, we would like you to report and submit. If you're sending to other lab, the core lab will report and submit what they test themselves. So if you're doing rapid testing in-house, we still want to hear about that data. So where do you get the data back from this? So I mentioned at the end of the booklet, every year you get this. We also send out these weekly lab surveillance reports. Once again, this has been very virus heavy, but it's evolving and changing. And so if you're not on the mailing list for this, anyone can be on it. It doesn't have to just be laboratorians. We send this to local health departments, infection preventionists, physicians, anyone can get on this mailing list. So if you're not currently receiving this and you would like to, please let someone here from the state lab know. We're happy to put you on that list as well. And this covers things like flu and, I've got my mouse over here, we go. Flu and COVID weekly updates on prevalence and case numbers. We also have in the bottom sections tested and percent positive for our enteric and respiratory pathogens down here, with a couple notes calling out specific things that are particularly high. We also have our section here on what we're asking for, since our surveillance can change depending on the season. We're asking for all influenza positive specimens in the off season, and then a handful of them during the regular flu season for more accurate surveillance. We also have some links in here for additional data on our website, which is another area we're really hoping to grow and expand. If you haven't seen it yet, our SARS-CoV-2 sequencing surveillance is in a live dashboard. It looks very sharp up on our website. We're hoping to move more of our surveillance data into more of these live graphs in the future. Another way that you can get this data back is through the DHS Respiratory Virus Surveillance Report. This is something, they take your data from the WCLN and put it into this respiratory report that goes out all over the state and is really helpful in monitoring influenza as it comes. And you can see the spike from this last season and what strain was within that as well. And then this respiratory virus graph is one that I check pretty often to see what happens to be circulating right now. And they'll even break down the influenza parts by region. So you can see in your region specifically, has flu started here yet? What's going on? Once again, you can sign up for this. If you're not currently getting it and you would like it, you can sign up on the DHS website under the Respiratory Virus Surveillance Report. So what is the value of reporting? What do we do with all of this data? So some benefits, big part for us here in public health: stop transmission, prevent future infections. Early recognition of outbreaks is really important to have this kind of data to recognize these. Tracking drug resistance and spread of pathogens, evaluation of vaccine efficacy, can inform on strains for future vaccines, help focus resources to areas that need it most, another public health response. And that trend data can be so useful at so many different levels. This can help doctors diagnose their patients by looking at a patient comes in with a respiratory syndrome, what's circulating? It can give you some idea of what it's likely to be if you have an idea of what's currently circulating in our area. This can also help you optimize your resources for testing. So if you know it's flu season, that it started early, that you can help adjust your staffing in the laboratory to make sure that you have that testing covered. Know when the season has started. That's a really helpful one. And the ability to detect problems with the test. This is something we really noticed in the past year with a couple of tests that people were using routinely in the clinical lab when they sent residual samples to us for additional typing, characterization, and they weren't testing positive. It helped us to recognize false positives in those tests that you would not otherwise have been able to detect through most means. So really helpful. Once again, we can work together as a partnership and share that information with each other. And so that goes to all the different people who use this data. Public health is, of course, at the core of this. That's why we're asking for this, but it's not just us. It's the medical providers, the laboratories, the public, and the media go and reference our data, and they use this to report on. It happened a lot during COVID. And even the manufacturers in deciding what strains need to go into future vaccines. So recognizing outbreaks is absolutely at the core of this, recognizing those trends and patterns and stopping transmission. And this data is reported nationally and helped to recognize a lot of different outbreaks. We see a lot of illnesses, hospitalizations, and deaths in just the past year from these different outbreaks recognized through the surveillance reporting. Now we see a whole lot of Sterkel, Listeria, and Salmonella especially that kind of come and go. A little bit of a dip in 2020, which I think is a trend we're going to see throughout this talk. Now, in the past year, so we've had a fair number of different outbreaks. So just to kind of briefly go over these, the most common things we've got just recently some Listeria in ice cream, Salmonella in ground beef, raw cookie dough, flour, and alfalfa sprouts, some Hep A and some frozen strawberries, more Listeria, but this time in leafy greens, so you can't do ice cream or leafy greens. You got some Listeria. What do you eat these days? And some norovirus and oysters. So once again, all of these are only possible to detect because of that public health surveillance. All right, let's get into the data itself, my favorite part. I love crunching numbers and seeing how this all ebbs and flows and changes from year to year. But I wanted to start kind of big picture, and we'll dive in a little bit, but not too deep into each pathogen. We just don't have time today. So I'm going to start with respiratory pathogens, and in the past year, break down by proportion of total positives that were reported to public health. Not too surprising, SARS-CoV-2, although it was a light year for SARS-CoV-2 compared to others, it was still the predominant respiratory pathogen that we had to deal with, still far out passing influenza, which was a pretty bad flu year this past year too. RSV was also a big one, and we had a particularly bad RSV year we'll talk more about, and then to lesser extent, rhinoviruses and enteroviruses, parainfluenza, human metapneumoviruses, Bordetella, and some seasonal coronaviruses. Now, if you really like respiratory viruses and you want to hear more, Al and Erica are giving their annual respiratory virus webinar in a couple of days, not too far out. So absolutely, I encourage you to listen on that as well.
Question on the last graph. So your graph of the percentages of breakdowns, this is what was reported, correct?
Yes, what was reported.
Okay. The percentages of some of the lesser viruses are smaller. I mean, that likely those may be smaller because there's a lot fewer labs that can report those, I assume, versus like my lab, it's flu, RSV, and COVID. That's all I can submit. So I mean, that potentially why those numbers also appear a little higher, or but likely R negative to everything could be a good chance one of those other viruses. We just don't have the ability to. Is that correct with this data?
Absolutely, yeah. We can only capture what's reported, and we can only get reported what's actually tested, and most people aren't testing for all of the rhinoviruses. So this is just scratching the surface of the rhinoviruses, probably, of what's out there. So absolutely, that's something to consider throughout this data. This is only what's actually reported. All right, so I'm going to start with COVID being our big one, and hopefully we're not too burned out to hear a little bit more COVID data here. We've all seen these graphs with the huge waves that we dealt with, and it was really nice to see in this past year that it was quite a bit less than what we saw previously, and this last summer was a really nice break. And unfortunately, we are seeing an uptick in percent positivity, which is an indicator that we're seeing a rise in cases again. Hopefully it's not going to be anything like what we saw in the past, but it does look like we're on our uptick for another wave right now as well. Diving in specifically to Wisconsin data, we see the same thing. This is the national data compared to the Wisconsin data. Same thing where we're seeing an uptick in percent positivity and number of positive. And in our wastewater sewage, this is another new way that we're monitoring for diseases that is independent for asking for surveillance data. And so this is something you can expect to see growing more and more as they're monitoring and looking for how can we best use wastewater sewage surveillance to monitor for the different things, what's worth monitoring, what's meaningful, and how do we use that data. But it also is increasing in wastewater right now too. This is just a little snippet from a small time range from our sequencing surveillance for SARS-CoV-2. You can see kind of what strains are circulating. Blue here is Omicron, and we do have, they've kind of stopped giving them new names at this point, so it's all Omicron, but they continue to have these additional lettering names, the pangolin lineage names here. And the one that's been in the news a lot is the BA.2.86, and we haven't yet seen this in Wisconsin. So if you ever get these questions, something comes up in the news about what, this new strain's coming out, is it in Wisconsin yet? You can go to our website and find out for yourself. Is it too dark? I'm gonna have to make it more lively now so we don't fall asleep, right? Okay. Now I'm going to switch into our influenza work. So for those who aren't familiar, we are a National Influenza Reference Center, one of 3 in the country. During flu season, we cover the states here in orangey tan, and in the off season we do the entire country. So we're collecting a spattering of positive influenzas to do additional typing and monitor for what strains are circulating, looking to see if there are new and emerging infections, but also monitoring to see what strains will be good to put into next year's vaccine. So really informative there. Looking at our last year's flu season, we did have a pretty large year, and it was pretty heavy into the flu A H3 here in yellow. Very, very little flu B. It was not a flu B year, as we'll talk about here some more, but higher numbers of hospitalizations and positive results reported than an average flu year. So it was pretty big. We often look to the southern hemisphere to predict what's going to happen in the future here, because their seasons are opposite, right? So they're just coming off of their winter season, their respiratory virus season, as we're coming into ours. So we looked down to Australia to see what their numbers were, and last year they had a very similar flu year right before us, very flu A H3 heavy year, and then what they just had was still a pretty heavy flu year for them, but now we see it looks like it's going to be a flu B year, possibly for us because it was for them, and the flu A looks like it's going to be the H1N1 instead of the H3. So we look at flu over time. We like to look for trends and patterns and what's changing. And as we monitor through this, it's kind of interesting to look through where we were before. Some years are small, some years are big, and it kind of goes back and forth, and it changes a little bit in seasonality. We kind of think of October as kickoff of flu year, but they were having a particularly bad flu year in early 2020 with flu B and A and higher peak than normal. And then something happened around March that really made things tough for us in 2020, and we put in a lot of practices with hand washing, isolation, quarantine, mask usage, and flu dropped off. It just disappeared, and it stayed gone for a year. And when it did come back, it was small and kind of a weird two-peak thing that was happening, a little unusual. We were still dealing with a whole lot of COVID during this time, and in this past year, it came back strong and a very large peak. Once again, there is a little bit of testing and reporting bias that can happen as we're looking more for this, but certainly we were testing a lot for flu in 2022 as well, and we didn't see the same kind of impact. So we had a pretty bad flu year, and it's been a while since we've had a flu B year, while we almost always have flu A. So it does look like we'll probably get a flu B year this year. An interesting little tidbit for flu, something that we've had a lot of discussion with, that there are two main strains of flu B, the Yamagata and the Victoria. Victoria does seem to still be slowly circulating in the background, but we haven't seen Yamagata since before the pandemic, and there's some early discussion that it may have been wiped out by our pandemic control efforts. Now this is really interesting as we look through the rest of our data and we look at the trends and patterns. All of those efforts we put into place to try to control the pandemic had an impact. They had an effect. They stopped transmission. Our public health efforts do work, and we'll see that trend kind of throughout our data today. Now, before we leave influenza, I do want to spend a little bit of time talking about the avian influenza. Now, thankfully, this did not really jump into humans, but it's another reason why we monitor for things, not even just human things, but animal things as well, because this really took off across the world, and the US was certainly hit pretty hard here with avian influenza. If you've ever wondered what it looks like to swab a duck, I threw in a slide because I was very curious, and someone at another meeting mentioned that you also swab the other end, but I didn't have a picture for that one. But the important thing was, because of our routine surveillance, testing a smattering of positive, testing high-risk patients who had had contact with infected birds, we could see that it wasn't jumping to humans. And if it did, we could quickly quarantine them, put those public health practices in place, and prevent the spread from this potentially zoonotic jump from the avian influenza. So this is another reminder that if you get unusual viruses, something that's not testing well in your lab, or they have a weird exposure, some laboratory exposure, animal exposure, and it's off season especially, we want those weird unusual things, not just influenza, but all the weird stuff. We love getting that weird stuff. It really helps us to recognize when there's new and emerging pathogens coming up. You guys at the front lines are the first to see these things. When you say, "That's funny," that's probably something public health significant, and that's where we've been able to detect things like the Elizabeth Kingia outbreak that we had. We want to hear about your weird and your unusual things, absolutely. We love zebras is kind of, should be a shirt that I need to get here. If you've ever heard the term, if you hear hoofbeats, think horses, not zebras, that's where that comes from. So respiratory syncytial virus is the next one I want to talk about. So historically, we've had reasonable size peaks, maybe a slow increase over time in RSV, but it's been very predictable season to season on when it comes, and the amount of RSV we're detecting is fairly predictable. But then during the pandemic, we saw a drop off in 2021. It just didn't seem to happen. But then it seemed to happen earlier for the next season and was larger than what we'd seen previously. And as we look through, what actually happened in the following year was an even bigger peak than what we had seen before, also off season from what we had seen. So in this graph, you can see on the right, previous years are all overlaid in shades of pink, very consistent in about the time of year that they hit. Now our 2022 peak came several months earlier and was twice as large as previous compared to our 2023, which was in between those two, but was our largest peak yet. Now, for those not familiar with RSV, this causes very severe respiratory disease in very young children, especially under the age of 1. It is the leading cause of hospitalization in children under 1. So we're certainly concerned about this, and it can cause death in this young population. It can cause severe disease in our older population as well. So just this year, we're very excited to hear, thanks to the new technology developed, in large part thanks to SARS-CoV-2, these new RNA vaccines are being utilized to quickly develop new vaccines. And there's now 2 vaccines out for RSV, one approved for older populations and then just more recently for very young populations. So as we're needing it the most, as we're seeing these huge, large waves causing increased hospitalizations and deaths in our young children, we now have a tool to fight it. Next, I want to talk about rhinoviruses and enteroviruses. This is a wide group of viruses that are hard to distinguish from each other. And we do get these multi-peaks throughout the year. So kind of more classically is right as school goes back into session, we get our first big peak, which if you hadn't realized is right now. So we're just coming into our big peak for rhinoviruses. And then it drops down a little bit and then comes back after the new year around March. We'll get a kind of a smaller second peak. But there's always some low level of these viruses circulating, and there's certainly a lot more that we can learn about them. And so we're currently developing some systems to further characterize enteroviruses as they might be involved in some other symptoms and diseases. Interestingly enough, there was a pretty big dip right as the pandemic hit, but it didn't take long to come back, and it doesn't really seem to be worse than it was before. I do want to qualify everything today that I'm not an epidemiologist, I'm a laboratorian, and so I might have some guesses about what's going on here, but really we don't know. And part of the value of this surveillance data is providing data for people to do additional research, whether that's public health laboratorians, whether that's epidemiologists, whether that's researchers in an academic setting. This data can be used at all of those settings to evaluate what changed and why, and how can we prevent infections better in the future. So next couple of viruses I'll go through a little bit quicker. Human metapneumovirus we saw basically disappear in 2021. Seems to be back to fairly normal since then, not much change, maybe a little more. Parainfluenza, this has 4 main viruses within the parainfluenzas, and they tend to circulate at different patterns. Para3 tends to come pretty much every year, but is a little bit more of a summer virus, which is your summer flu, while the other ones, like Para1 is usually every other year, same with Para2. Para4 tends to be seasonal, more like with the influenza season. But you can see across the board, when you overlay them all, there was real wipeout during our pandemic efforts, and they do seem to have come back a little bit stronger and a little bit off season, and viruses that used to be in even years are now popping up in odd years, and so things are still kind of evening out. Not exactly sure what it's going to look like, but hopefully we'll see it coming back into predictable patterns again in the future. Next are our seasonal coronaviruses, the coronaviruses before SARS-CoV-2. These are common cold viruses, and there's 4 main ones that we're tracking here, and they are very similar to parainfluenza. We don't have a summer seasonal coronavirus, but we do have kind of every other year viruses like the 229E, and with all of them took a bit of a dip during the pandemic, but they didn't really see the same hit that other things did, which is interesting, and I'm not sure why. I do want to throw up a quick slide on pertussis. Because this is a vaccine-preventable disease, it could fit in a couple parts of my talk, but this is an interesting one that used to be incredibly common, whooping cough, and we'd have large outbreaks, so it's certainly one that we monitor closely for public health purposes. However, thanks to vaccination, it has dropped down significantly, and so we don't see a lot of numbers. And during the pandemic, we saw really the numbers very, very small, almost to like background false positive rates at this point. But interestingly enough, parapertussis, which we also monitor for, which has been very, very low for a long time, had a little bit of a wave this last year. So something to watch for. Still very, very low numbers. I'm not sure the significance behind this, but certainly want to share the data with you. Tuberculosis is another thing worth mentioning. I won't go into this too much detail because we have an entire conference for tuberculosis. This happens usually every October, November. This year it's going to be November 8th at the Doubletree. Registration information is already open, so if you're interested in mycobacteriology, please come join us for this conference. It's also like this, no registration fees, and we give you lunch. If you have any questions and would like to register, please contact our TB team lead, Nate Simon. His contact information is here. So a bit of a busy slide, and he'll go into a lot more detail during the full conference for this, but just to quickly summarize, there were 45 new cases of TB in Wisconsin in 2022. We do susceptibility testing on those, and 76% of them were pan-susceptible, so that's really good news. There was some monoresistance to isoniazid and pyrazinamide, and some that had multi-drug resistance as well. We also monitor for the non-tuberculous mycobacteria. Not too surprising, the M-avium complex by far outweighs everything else. So this is our blue section here. There's quite a bit of that. The next most common NTM that we identify in the lab is the M. gordonii/paragordonii, which is not a human pathogen. This is a contaminant that kind of slows us down in the process in the laboratory. After that, we have the Chelonae abscessus, fortuitum group, Mucogenicum, Xenopi, and other rapid growers below that. So we're currently working to expand our testing here as well into whole genome sequencing and some other fun new technologies. All right, let's switch gears into enteric surveillance. Similar to the last time, very broad picture, breaking this apart: bacteria, viruses, and parasites. Vast majority of our enteric disease is due to bacteria. So we're going to dive into those first. And of the bacteria, most of our enteric reported diseases are E. coli, of the many different kinds of E. coli, kind of all lumped in here together. After that, C. diff is still pretty significant numbers. Campylobacter and Salmonella make up the other major players here. We are a pretty big state for Campylobacter here compared to some of the other states where Salmonella is more prevalent. So diving in a little bit more detail, since the implementation of these multiplex panels, these molecular panels that people have been using, we're getting a lot more data on the different types of E. coli. We weren't sure how significant this was. We were asking for a lot of this data for a while, and we can kind of see the breakdown here. But in the end, we found that we weren't really using this data for anything. It wasn't really telling us any new insights. And so we're now asking for general E. coli reporting instead of all of the individual subtypes. But if you're curious, the majority is EPEC. We do still care about the E. coli 0157. Shigella is pretty rare. This we see only kind of spattering numbers here and there, but no real impact during the pandemic. Campylobacter, I mentioned, is one of our bigger ones, and as with most of our enteric bacteria, this is summer seasonal, and once again, no real impact from the pandemic. You're thinking these fecal-oral transmissions may be a little bit differently impacted by our respiratory precautions that we took for the COVID. Same with Salmonella, so we see seasonal summer waves as usual, but also not a major impact from the pandemic. And let's throw in some fun stories about Salmonella outbreaks. So backyard poultry has historically and continues to be one of the most common sources for Salmonella infections. And so this can be outbreak sources. People buy chicks from common places. So this is certainly one that we've monitored, but this one had, when I pulled this, 690 cases all associated with a specific investigation. There was also a recent one here with Salmonella linked to small turtles, pet turtles coming from a common source. C. diff is something that we've been monitoring as well. We know that this is really important in your hospital settings, but not something in the public health realm that we generally are able to do much about. But your infection preventionists and your hospitalists all work together, I know, to fight this. Now, we had been seeing steady rises in C. diff in different hospital settings, but it seemed like we were starting to control it a little bit, and then the pandemic hit, and we had a lot more people coming into the hospital system, and a lot more efforts on controlling COVID spread, and maybe a little less on C. diff. It's hard to predict exactly what happened here, but we did see a pretty significant increase in C. diff positives being reported, and then a really sharp jump in late 2022, and then it seems to be coming back up. So I'm not sure exactly what all happened here, if there's some reporting artifacts. Wanted to share the data with you. Going into our viral enteric pathogens. Now some of these are summer and some of these are winter. By far and above, norovirus is our most common viral enteric pathogen. But we do see a smattering of these other ones thanks largely to our multiplex enteric panels. So back there, things like sapovirus kind of peaks in December, while you've got noroviruses generally in March, more similar also to your astrovirus, and some seasonality looking more towards May, June over here for your rotavirus. Going in individually within these viruses, so we do a lot of norovirus surveillance and some additional typing. The vast majority of what's circulating is G2, with only about 18% being G1. And there was an impact during the pandemic that cases did drop with norovirus, but seem to be back to normal now. Sapovirus also had an impact. So interesting that our viruses were much more impacted than our bacteria were, but also seems to be generally back to normal. And same thing with astrovirus. A little bit of a hole there, but it seems to be back to normal, but maybe a little bit of a shift on when the peak hit. Same with rotavirus. This one, we tend to have some big years, some low years historically, but we'd had 2 very, very low years in a row, but that does seem to have come back. And adenovirus, very low incidence to begin with, but did take a little bit of a gap during the pandemic. Now into our parasites. We're a pretty hot spot in the country for Cryptosporidium, but we do see a lot of Giardia here as well, and a little bit of Cyclospora and Entamoeba histolytica. These are more summer virus or summer pathogens, parasites as well, but you can see them pop up at other times of year too. And they're often associated with outbreaks, which is why we monitor for these compared to some of our other ones. Diving into Cryptosporidium a little bit, there really wasn't too much of an impact during the pandemic, maybe a little bit, but not really detectable. Once again, we're a pretty big hot spot here. The largest outbreak in the world ever was in the Milwaukee outbreak, if you remember that. There are many different species of Cryptosporidium, and we're all really reporting generally Cryptosporidium positive, right? Our top 2 most common species that we're finding are parvum and hominis, but Wisconsin has a pretty high number of these weird, unusual other types of organism or species as well. So we're doing some additional genotyping now. We can see kind of these interesting numbers. A15G2R1 from the 2A family is our predominant one here in Wisconsin, but we do see a wide variety and smattering of other things. We're just starting to collect this data and really interested to see how we can better use this to recognize outbreaks of Cryptosporidium that we couldn't previously detect because we weren't doing this kind of relatedness testing. So next is Cyclospora. This tends to have a pretty sharp spike in the summer, and it's usually outbreak associated. Been pretty consistent the past 6 years despite the pandemic. Some years we don't have much at all. Like I said, this is more outbreak associated, but we've consistently been having outbreaks. Giardia, lower numbers for this one, maybe a little bit offset, but not much detectable difference during the pandemic. And now on to our invasive infections. Now I mentioned before that this is a little bit of a catch-all group. We are looking for things causing CNS disease in sterile sites. So we're looking for things like Haemophilus influenza, Listeria monocytogenes, Neisseria meningitidis, but really anything weird and unusual. This is where we kind of have that catch-all ask for this. And as I mentioned, this is where we detect things like Elizabethingia. Streptococcus pneumoniae fits in several categories. It's vaccine preventable, it's invasive, it's antimicrobial resistant, so all the things together, so I'm just kind of throwing it in this spot. But this is an interesting one where we saw, thanks to vaccination, a 99% drop in pediatric cases after the first vaccine was released, and that's the PCV7. And since then, we've had some additional ones, PCV13, and now there's 20 out there, and they've continually added more and more serotypes. So that's what that number there is at the end, is additional serotypes that they're adding. And they're adding those based on our surveillance data that we're collecting here. So we're one of 2 strep pneumo surveillance sites in the country, and we're looking at what strains are currently circulating and whether or not they're part of a vaccine. And this helps to decide on what strains should go into vaccines. As you vaccinate, certain strains disappear and other ones become more prominent. So this can be an ever-evolving situation as we try to control this. And this is just a single point in time. So while we do have some that are kind of high that are in a vaccine, this 15B, 15C is really only in the 20 version that's given to older populations. Vector-borne pathogens, another thing that we monitor for here. So we've got on our request list for positives for malaria, babesia, and Ehrlichia that don't have a species that's known. Now, fortunately, we don't have any locally acquired malaria, but we are monitoring for this and can do some additional typing and testing for this. Unlike some other states in this past year who have found some locally acquired malaria cases, which you'll hear more about later today. Babesia and other tick-borne diseases has certainly continued to increase. So I wanted to kind of show that trend over time as well. I threw up a little data for ehrlichiosis. While it continues to be fairly rare, we do have this summer seasonality as the ticks and humans have more contact with each other, and our predominant strain is Chafiensis with a little bit less of our Murus oeclarensis. We tend to be a little bit of a hot spot for that organism, and then a tiny bit of Ewingii in there. Some more tick-borne diseases. Powassan virus continues to be rare, but does look like it's still trending up. And Lyme disease also continues to trend up. Arboviruses, this is another thing we do a fair amount of testing at the state lab for. The numbers are so low for some of these that this is cumulative data over many years to try to put something together. West Nile virus continues to be our most common here, and this one tends to come and go. Not sure the reason behind. I'm sure a researcher could tell me in more detail. But this one, we haven't had much in the past couple of years, so maybe we're due for a spike. I'm not sure. Jamestown Canyon virus, a little bit more common up north. Once again, this is multiple years data, 2017 to 2021, and 2012 to 2021 to get this more southern location of the La Crosse encephalitis. We've only had 7 true cases of eastern equine encephalitis since '64, so this continues to be an incredibly rare disease in Wisconsin. And Zika virus, which was a very hot topic for us for a number of years. We haven't seen any cases in Wisconsin for quite some time. Once again, this was all travel associated, and in general, we're seeing less around the world. Hepatitis A, this is one within the United States that we have seen a real jump in the past couple of years. It causes quite a few outbreaks. So in just the past year, we've had nationally over 44,000 cases, 61% hospitalizations, and 429 deaths, which is really sad to think when this is a completely preventable disease with vaccination. So when we get reports and we hear about clusters and potential outbreaks, this spurs a public health response to vaccinate in those areas to prevent additional spread. Here in Wisconsin, and these numbers are a little backwards, so it's further in the past down here, we had a lot more cases, and now we've moved towards the future. We're getting fewer and fewer cases as we've had a big push for vaccination here in Wisconsin. Hepatitis C also seems to be having a general upward trend nationally. We're not the hottest spot in the country for Hep C, but we're still one of the more prevalent states. And here in Wisconsin, in the past, between 2020 and 2021, we did see a significant increase in the rate of HCV infections. So something that we're monitoring for, often transmittable by IV drug use, no vaccine available, unlike Hep A. And so this is part of the reason why we applied and were awarded grant funding to enhance our surveillance for hepatitis C. So if you've seen our requests come out, we're still very eager to get residual positive serum from your Hep C testing to do sequencing typing for this. This is a platform called GHOST, which is the Global Hepatitis Surveillance Testing, and it provides these beautiful clusters here to help us recognize transmission networks, prioritize our public health resources, and help stop the spread of this. So if you have any questions about how to submit, what to submit, and then if there's anything that we can do to help support that, please let us know. Group A strep is another one I wanted to talk about. This is some national data here showing a general increasing trend in invasive group A strep infections. And we've had a pretty large uptick just this past year. So this is in Wisconsin laboratories looking at our reporting, and it was pretty predictable prior to the pandemic, right? We had generally around the same time of year, generally similar volume in positives reported. There was a significant cutoff during 2021 season around the time the pandemic was really hitting hard, and then it came back about twofold in 2022. So some theories I've heard are that the population was more susceptible after getting a year off. But when we had this last peak here in 2023, which was really significantly increased compared to previous years, yes, we knew more was circulating and are probably doing more testing for it, but we certainly saw a lot more clinic visits associated with this as well. We certainly had a very big group A strep year. Again, not entirely sure all the reasons behind it, but certainly something that we'll be watching for this next year as well. Fungal infections, just to mention that we still are interested in this as a reportable disease for particularly our endemic fungi. Like, we are a very big hotspot for blastomycosis here in Wisconsin, and we also overlap with histoplasmosis. And we do a fair amount of testing for Candida auris here in Wisconsin as well, and you'll hear more about that from Megan Lasure later today. We're not the hottest spot. You can see there are some other more endemic areas for that now. So Megan's going to give us a whole talk through antimicrobial resistance. This is a very fast-growing, very large, significant proportion of our work, and so we gave an entire lecture to this. The only thing that I'll mention on this before passing it back to her is that there was a significant outbreak in the past year. Wisconsin was associated with the investigation of a highly drug-resistant Pseudomonas associated with teardrops, or eye drops, artificial tears, that were contaminated with this multi-drug resistant strain of Pseudomonas. And thanks to that surveillance and sharing of data on a national level, we're able to identify that this was an outbreak and stop the spread of this disease. All right, vaccine preventable diseases. We're also National Reference Center for this work. Our region is a little diverse for this. However, CDC set that up. We cover the yellow states there. And the kind of testing we do as a vaccine preventable disease reference center includes identification and genotyping for measles, mumps, rubella, varicella, pertussis, H-flu, and meninge, and strep pneumo, which we kind of already mentioned a couple of those already. This is helpful. I didn't mention this before, but another way that we can use this testing is not only to monitor for what strains are circulating, how well those vaccines match, but also for individual patients. If they have been vaccinated but still got a severe disease, our data can be used clinically to evaluate, did they not respond to the vaccine, or was this not a vaccine strain? Do they have an immune defect? This is something that can help to inform on that too, and can be useful when we're dealing with different kinds of outbreaks. We're one of the few labs in the country that can do measles typing to see if it's a vaccine strain versus a wild type strain. I kind of mentioned that already. So measles, mumps, and rubella are fortunately very, very rare. A nice downward trend in mumps, and we've seen very little in the past couple of years. Same with measles. We very rarely see measles at all. We did have that big spike around the 2021-2022 mark, and if you recall from our previous presentation, this is when we had our large influx of Afghan guests that came into Fort McCoy, and unfortunately, being a highly contagious virus, as they were all transporting on these same large planes, a lot of them got measles. But thanks to a very great public health response, we were able to contain it, and we didn't have any identifications outside of that base. Only 3 rubella in the past 16 years, so that one continues to be incredibly rare. VZV, or varicella zoster virus. This has the 2 main presentations, chickenpox generally in children and shingles in adults, and it's been really fabulous to watch with our surveillance data how this has been impacted by vaccination. So the vaccine was really implemented and widely recommended in '96. So if you're like me, I think most people here were born before '96. You may have been submitted to a chickenpox party when you were a kid, right? So my parents did that to me. We all intentionally got chickenpox together so that we wouldn't get it as an adult where you can have a more severe disease. If they'd only waited a few more years, I could have gotten vaccinated. So if you're like me, and 99% of people over the age of 40 at this point have had chickenpox at some point in their life, which means that they are at risk of having shingles as the virus reemerges. And sometimes this is highly annoying, irritating, painful, usually on the trunk, but other times it can go near the eye, like we have pictured here, and it can have some really detrimental effects, which is this graph up here, is people the older population is at greater risk not only for shingles infections, but for severe complications like peripheral hepatic neuropathy. So as we look for the decline in chickenpox after the childhood vaccine, and we look at the adult vaccine, this live attenuated virus, and how it impacts shingles itself, it has less of an impact in preventing shingles. It seems to be about 50% effective for about 5 years, but then they implemented a new one called Shingrix, which is now 2-dose, and this does seem to be dampening down the incidence a little bit more, but it's really exciting when you start doing the math. Recommendations for shingles vaccines are for people 55 and older, which means in 26 years, all of these children who are getting vaccinated now won't need a shingles vaccine because they'll have been vaccinated as a child. And so this is really that beautiful impact as we watch to see how vaccines are making a difference, and helps us to know how we should be directing our testing. What is actually circulating? What are our risks for getting these different diseases? So overall, we're continuing here in Wisconsin to see a downward trend, and there aren't a whole lot of cases being reported of primary VZV infections. I want to spend a little bit of time on STIs as well. This is becoming an increasing problem in Wisconsin. So looking between 2014 and 2021, there's been a 41% increase in STIs being reported. There are only 3 STIs currently that we request data on, and this is syphilis, gonorrhea, and chlamydia. There are, of course, many others that are even more common. HPV, trichomonas are also very common diseases as well, but I've only got data on these 3. So of these, I think everyone's pretty familiar. Chlamydia is the most common, with gonorrhea and syphilis after that. Now, if you're like us, we saw a drop in the demand for STI testing during the pandemic. A lot fewer people were going to clinics to get tested. And hopefully maybe there was less contact that was causing transmission of these diseases as well. But this also meant that some people who may have been infected may not have been seeking care like they could have. So there's a lot that goes into this as we evaluate what was that impact of the pandemic. We did see a decline in the rate of reported chlamydia cases. Once again, was this because there was less or because people were going to the doctor less? Interestingly enough, we did not see a matching change in the gonorrhea rate. And in the past year, syphilis didn't really take much of a hit right during the pandemic, but has been coming back with a 100% increase between 2020 and 2021. So I wanted to dive into syphilis a little bit more. This has been a growing problem for a number of years nationally. When you look across the country, 2011 to 2020, particularly in the South and on the coast, syphilis has become a major problem. We don't have a vaccine for this, but it's perfectly treatable with penicillin and preventable with the right precautions. So it's really discouraging to see that this has been going the wrong direction. We need to refocus our public health efforts on this. Here in Wisconsin, we are seeing a general trend upward, but in the past couple of years, it was a lot more than usual. Now, Milwaukee is historically, as a dense population center, a really high site for syphilis in our state, and it continues to be, but it had a pretty big jump in that year period. Unusually, though, we saw a huge jump in Sawyer County. Now, compared to our other counties, Sawyer used to be very similar to its neighbors down here. We saw a huge increase, and this helps us to recognize that there's an outbreak going on and help us to focus our public health resources in that area. Now, we can't talk about surveillance data in the past year without mentioning Mpox. This was certainly an interesting experience for all of us. So this was historically a select agent, but thankfully the clade 2 is not a select agent and was being transmitted in an entirely new way than we'd seen monkeypox transmitted in the past. So this is why it's in my sexually transmitted infection part of this talk. Overall, we saw this almost perfect epidemiological curve of Mpox as it really quickly became incredibly common throughout the country and then dropped off nicely after vaccination efforts were implemented. And in the past year, you look at the scale is much different here, 10 to 12 compared to 600 over here. We've had just a smattering of cases, a small wave over the summer, and then we really haven't seen maybe onesies and twosies in the country now. This is not just Wisconsin, this is the whole US data here, and they have officially declared the outbreak over. So very exciting to see this and exciting to see how our public health efforts have really made a difference. The last thing I want to leave you with here is Chronobacter. So this has been recommended by the Council of State and Territorial Epidemiologists in a position statement to become a nationally notifiable disease. It has been associated with outbreaks of infection in infants associated with formula. So this is one that they want to monitor for more closely to recognize these outbreaks earlier and prevent additional infections in this very vulnerable population. So expect as the nationally notifiable becomes reportable, required to report, it will eventually become required here in Wisconsin. In the meantime, we'll probably ask for that through our WCLN requesting data until it gets on that state reportable list. With that, I'm going to leave you with some resources here, and happy to address and discuss the data and any questions that you may have. Tom,
Okay.
You've always got a question for me, Tom.
We can also use the microphones if people want to come up.
Oh, yeah, sorry, being lazy. So that's interesting with the drop in chlamydia, but not, what was the other one, gonorrhea?
Gonorrhea, yeah.
So what do the epidemiologists think about that?
Well, I've heard sneak peeks of the latest data, and there's actually a drop in gonorrhea that's just occurred. And so we're still looking into, they're trying to find out why. Is this because of different cultural things? Is this because of different exposures? Is this because of public health measures, testing frequency? We're really not sure. I think that there's a lot of different things behind this, but I think that they spend almost as much time on when there's unexpected drops as when there are increases, because whatever we're doing, we should do more of that, right? So not really sure why they were so different. Did you see a big drop in your testing for STIs when the pandemic hit as well?
I think we were really paying attention.
Fair enough.
Yeah, totally fair. We were happy we moved some of our staff off of STI and onto other things, yeah.
Any other questions this morning? A lot of data. You can see how important it is, all of those specimens, all of that data that you submit, and it really is useful, so thank you. We really do thank you for that. If we don't have any more questions, we're going to give Dr. Sterkel a round of applause. Okay, and then our next speaker is going to be Dr. Bateman, so I will let him get himself ready, and he's going to give us a lesson in Transfiguration.
All right, so I'm going to be talking about next-generation sequencing and the rapid adoption of sequencing in public health labs, and specifically at the Wisconsin State Lab. So overall, first I'm going to start out with a general overview of next-gen sequencing. I'm just going to walk a little bit around to talk to each of you, each side. Talk about next-generation sequencing as a technology and the main use that we use it for, whole genome sequencing, so sequencing the whole genome of pathogens. Then I'll talk about the primary uses, things we've been using this sequencing for many years, additional uses, and then a little bit of thoughts about the future of NGS. So next-generation sequencing obviously had to have something come first, and the first generation was called Sanger sequencing. It was developed in the 70s by Frederick Sanger, and essentially it is taking each A, T, C, and G, each nucleotide, and labeling it with a different color. And I won't get into it too much, but essentially in the end, you get this chromatogram of peaks. So you get a green peak that says that one's an A, a blue peak that says that one's a C, and so on, so you can read off the sequence. And this is really, really accurate. It was the gold standard for a really long time, many decades, but it's not that high throughput. It's relatively small numbers of base pairs you can do at a time, so you have to limit the amount of sequencing that you can do and the amount of a particular genome that you can do at one time. So when they worked on the human genome sequence, they had to do massively parallel instrumentation. This is a picture of the human genome being worked on, and each one of these gray boxes here is a Sanger sequencer. So it's just sequencer next to sequencer next to sequencer next to sequencer, because that's what they needed to get the entire human genome, because the throughput just wasn't quite there. And to illustrate kind of the impact of what next generation sequencing had, this is the cost per human genome on the y-axis and then year on the x-axis. You can see it was pretty much following Mohr's law of halving every single year until about 2007, 2008, 2009, where it really, really dropped. And this is right when the first next generation sequencing instruments started to come out. Roche 454 and the initial Illumina instruments. And it's really continued to drop even more, and the ongoing saying is that pretty soon the bacteria will be paying us to sequence them. It's getting really, really efficient and pretty cheap. So here's just a snapshot of a couple of the instruments from one of the major players on the market, Illumina. We use a lot of Illumina because CDC programs use a lot of Illumina sequencing. There are many others on the market, but Illumina really is the largest player. So overall, what next generation sequencing is it's massively parallel. So within one instrument, you're doing a lot of different sequencing all at once. And you get millions of different short DNA reads or strands, maybe 50 base pairs up to 250 base pairs, something like that. And each one of these is A's, T's, C's, and G's, all reading off the sequence. But you get a lot of these really short reads. And it's a lot of them. We're talking big data. Some of our runs that come off on like a NextSeq, which is a higher volume instrument, one run is more than 800,000 book novels of information. So you think about one novel, how many letters and words there are in that one novel, 800,000 novels in one particular run. So this is really, really big data. When I say massively parallel sequencing, it's really massively parallel. And next generation sequencing is the technology, and that technology can be used for many different applications. And one of the most common applications, the one that we use the most, is whole genome sequencing of particular pathogens. And there's 4 main steps in NGS testing. You start with nucleic acid extraction, then it's library preparation, sequencing, and analysis. And I'll walk through each of these in more detail. But first, I'd like to have the first clicker question here. So your experience in next generation sequencing is A, you haven't heard of it, other than the past 5 minutes. B, you've heard of it, but you don't know all that much about it. C, you've learned a decent amount about it. D, you've performed it yourself. Or E, you could be giving this lecture. And I'll take volunteers if you click E to switch spots with me. All right, the answers are starting to trickle in now. Let's see where people generally are. Okay, we got a pretty decent distribution. Most people in that B and C, so heard of it but don't know much, or have learned a decent amount. Sounds good. That'll help kind of tailor some of my explanations. So the first step in NGS testing is to extract the nucleic acid. So this is taking the DNA or the RNA out of whatever sample you have, whatever pathogen you're looking for, and getting rid of all the other stuff, all the carbohydrates and proteins and everything else that you don't care about. And you can do this in a very manual way. You can do a QIAGEN spin column, which is really good and really sensitive, gives good quality, but it's very manual. It's many different pipetting steps, and it's really low volume, one specimen, 5 specimens. I would not want to do more than 10 or 12 specimens at a time. And we do a lot more than that. So we don't usually use the manual. We usually use more automated extraction instruments like a Magnipure 24 or an eMag. And this can do 24 on this side and 24 on this side. So it's sort of like 2 instruments shoved together. And for these, you load in your samples 1 through up to 24, and you put in your supplies and reagents, and you hit go. An hour or 2 later, you have the purified nucleic acid. It's much nicer and hands-off. So the next step after this is called library prep, and this took me by far the longest to really understand, so I'm not going to go into very much of the details, but essentially you take whatever nucleic acid that you've extracted and you break it into small fragments, those 50 base pairs to 250 base pairs in length, and then you use primers to add barcodes to the ends of each fragment. So what you do at the very end of all of this is to take your samples, maybe 16 on a run or maybe up to 96 on a run, and you pool them all into one tube, which feels really weird in a diagnostic lab sense because you usually keep all your samples separate. You don't want to mix them up at all. But here, because this is so massively parallel, you can sequence 16 Salmonella easily on one MySeq run, or you can sequence 400 SARS-CoV-2 easily on one NextSeq run. So you really want to pool all of these, but then you're going to get these millions of reads. How do you know which one goes to which sample? It's by these unique barcodes. So in this one, at the very end, you get some blue and some orange, and so you can say, okay, that blue and orange combination, that went to Salmonella sample number 1. The green and the red together went to E. coli sample number 2. So once you have all the data and you're analyzing it, the very first step is to take those barcodes and put them into the buckets of all of these reads go to sample 1, all of these reads go to sample 2, so you can keep them all straight. And essentially that's what you're doing with library prep. You're putting it into these short fragments and you're labeling it to be able to keep each sample straight. And then you do the sequencing, and this is where a lot of the technical magic in the past 15 years has happened. There's a few different ways of doing it, but this one, the 4-color chemistry from Illumina, is very similar to the old Sanger, where you label A's, T's, C's, and G's with each with a different fluorophore, and then you add these in turn, and if you get an A, or if you get a red pulse of light, you know that was an A that was just added. If you get a G pulse of light, you know that was a G that was just added to that particular sequence. And when we say massively parallel, this is a snapshot of the flow cell. So there's really, complicated microscope and camera looking down at this, and each one of those different colors is one of those little reads, those 50 base pairs to 250 base pairs in length, and every time you add something and you get a color, you can say on that particular read, that was an A, or this one over here, that was a C. And there's millions of these all at once, and that's why you can do a lot of sequencing at the same time. So analysis-wise, first of all, after you figure out all the reads that are sample 1 and then all the reads that are sample 2, then you look within each sample and you take all those reads from sample 1 that was a salmonella and you line them all up and you map the whole 5 million base pairs of the salmonella genome. And you can do that in a couple different ways. We can get into it if you have questions later. But essentially, that's that consensus sequence. That's your whole 5 million base pairs of the genome. That's what you care about. You can throw away all the other little short reads and everything. Once you have that consensus sequence, that's what you use for anything else that you want to use this for. So you can take that salmonella and then compare it to another salmonella and say, are these related? Are these really similar, and so they might be associated with a cluster of foodborne outbreak or foodborne illness, or are they really separately related, so definitely not related, not part of an outbreak at all? You can look at what's the salmonella genotype or subtype. You can look at antibiotic resistance genes in any particular bacteria you sequence. And you can also look at primer and probe binding sites for PCR. So PCR, you have usually 2 primers and 1 probe in the middle that are really sensitive and specific for just that pathogen to be able to say, for instance, is salmonella there or not? Or is influenza there or not, positive or negative? And with the sequence, knowing the whole genome of the sequence, you can look at those sites and to make sure that there's no mutations within those sites that could potentially lead to false positives or false negatives by your PCR. So the actual analysis-wise, there are some commercially available point-and-click software where a dummy like me can do a point-and-click to analyze whole genome sequencing. But a lot of it is really bioinformatics heavy Linux-based coding where specific skill sets, specific experts are needed for this. We've gone from having one bioinformatician in 2017, 18, 19 to now we have a team of 6 that are doing this. And many state public health labs have also really boosted up their bioinformatics team. And there's lots of different quality steps. I've just thrown up one particular workflow here. Generally, they look kind of similar to this. And a lot of them are different checkpoints along the way to make sure that the data is quality, that the assembly is good quality, that every analysis along the way, there's a lot of different quality checks. So for whole genome sequencing, one of the main things we use it for is you have a bacterial isolate growing on a plate. You take that isolate, that is about 5 million base pairs. You put it through the whole sequence of extracting, library prep, sequencing, and analysis. Once you sequence it, you get these millions of different reads here. And in the analysis, you put it back together in the final consensus sequence, which is somewhere around 5 million base pairs. Usually, there'll be some little spots where you don't get any coverage. So just notice there's no reads right here. So we can't really say what was actually there because we didn't get anything that covered that particular position. And there are certain types of genome spots in the genome. If there's a hot spot of G or if there's a lot of repeats in a genome, sometimes it can be hard to really, it's called read through that. So you get a little bit of a break there. But generally you get upwards of 98, 99% of the whole genome by doing this approach. There's another approach called metagenomics where rather than starting with an isolate on a plate, you have just a sample, say a nasal swab, and you want to see what is generally there. So you say, sequence everything in there. I don't care if it's bacterial or human or virus. And then you have all these different reads. Each one of those colors is from a different thing in there, a virus or a human or something. And you can ask a couple different types of questions with that. And I'll use an example at the end about metagenomics. And so a quick comparison of overall molecular methods. So we have PCR, where you're going to target a very small proportion of the pathogen genome, and you're just going to say, is this pathogen there or not, positive or negative? With Sanger sequencing, usually, again, it's a really small proportion of the genome that you're targeting, usually less than 1%. If you have a really small genome like a virus and you look at a large proportion of that, maybe you can get up to 5 or 10% of the genome, but it's still a pretty small proportion of it overall. And you can look at, with Sanger sequencing, you can look at genotype or subtype or potentially relatedness if that small part that you're targeting is a hypervariable region and you can really tell if things are related or not. But that's not a super common use of it. The really nice thing about next-gen sequencing is you can look at the entire genome. So you're looking at relatedness using the entire genome. And for us in public health, that is the magic of this technology. Of any pathogen there is, you sequence the whole genome and you say, is specimen 1 related to specimen 2? If it is, much more likely that it's part of an outbreak. So overall uses of genomic surveillance at the state lab. First of all, just in general, I wanted to walk through a few of the different applications of next-gen sequencing in infectious disease. So the main thing for us in public health is to identify and respond to outbreaks. Again, because we can do this comprehensive genomic characterization, we can say, are these things related or not? And there are a couple different things that are national surveillance. So you heard Alana talk about PulseNet with Salmonella, Shiga-toxin E. coli, and Listeria. We at the state lab try to sequence every single Salmonella in the state, every single STEC, every single Listeria, and every other public health lab does that as well. And we upload that into a national database to look for relatedness, for clusters, to identify outbreaks, whether it's a smaller outbreak within a particular county in Wisconsin, or whether it's a national outbreak. We can identify this by trying to sequence every single positive that we can get. TB is a similar way. CDC has funded the Michigan State Lab to sequence every single TB in the country. So it's about 9,000 each year, and that's looking, again, for clusters, for relatedness, so that if there is an outbreak of TB in a particular area, we can identify it and really respond with public health measures. And there are many other examples of smaller outbreaks where if there's a particular cluster of disease of whatever pathogen within whatever type of facility, you can take those positives, sequence them, and say, are they related or are they not? If they are related, it's much more likely that you have ongoing transmission within that facility. But if they're not related, it's much more likely it's multiple different introductions, and it's sort of a bad luck in that particular facility at that time. So we can also ensure that vaccines are effective, and Alana mentioned this a little bit too, but we track the strains of flu and SARS-CoV-2 to make sure that that our vaccines are up to date with what's actually circulating at this time. We can also use WGS for bacterial serotyping. Right now, for half the country, the testing that we're doing is endpoint PCR based, where we're running 8 separate gels, and we have a lot of different bands on the gel, and it's very manual, and it's 40 plus controls that we need. We really want to get away from that. We have automated instrumentation that we can just do the whole genome sequencing and find the serotype out that way. It's a much nicer, easier way for us in the lab, better workflow, and very accurate for serotyping. And then I mentioned before, you can ensure PCR test accuracy by looking for mutations in those primer probe binding sites. And then one last application is to ensure that treatments are effective. So on the virus side, we can predict influenza antiviral resistance just by looking at the genome itself. We used to do a ton of in-lab phenotypic antiviral resistance testing. Now we do none of that. CDC does a very small number of those each year. But we've completely flipped the order that we do things. Now we sequence almost all the influenzas that we get because CDC has mapped each of the individual mutations that we know predict antiviral resistance. So we can just, again, sequence the whole thing and see which mutations we find. And then back about a year or so ago, SARS-CoV-2, we really used the sequencing and which variants were circulating to guide monoclonal antibody use. On the bacterial side or on the non-virus side, we can use NGS to guide treatment in other ways. If everything else is negative, but the ID doc still thinks this is something that's infectious, we can do that metagenomics and see what else might be there. Maybe some weird leptospira or some other pathogen that we don't routinely test for that can identify and then help treat that patient. Or we can predict antibiotic susceptibility for faster targeted treatment. And one of our projects right now is actively working on TB, where when we have a positive TB culture, we do the whole genome on TB to be able to identify potential mutations that confer drug resistance. And this is so much faster than culture-based TB AST or TB DST susceptibility testing because TB grows so slowly. So we can get an answer hopefully in a week or two rather than 6 to 8 to even more weeks after that. I will say on the non-TB side or on non-fastidious organisms like your normal E. coli or your Staph aureus, current approaches in clinical labs of culture and overnight AST really are the gold standard, and I think will remain the gold standard for a while because the turnaround time and the cost of next-gen sequencing is just not there yet. The cost is way too high, and our turnaround time is more on the level of days, and because we batch sometimes to control cost, it's like a week or so before we get things. Definitely you don't want to wait that long for your E. coli AST. So things that we've used next-gen sequencing for a while now. SARS-CoV-2 genomic surveillance, we sequence it, and then we have the sequence that we can use for many different things. We can obviously track the lineages and the variants, inform that monoclonal antibody use, vaccine strain selection, and ensuring those tests remain accurate. Here's an example from almost a year ago now where bebtelovimab was no longer authorized the FDA actually pulled the authorization because the currently circulating variants were resistant to that. And there were, back in the day, a lot of different monoclonal antibodies that we used one, and then it would become not effective because the virus mutated. We use another one, it would also become non-effective. Now, the past almost year or so, the Omicron variants that are circulating are resistant to all of them, so it's not really a thing anymore. But back in the day, it was really used to guide which treatments were effective and which treatments were even available, FDA approved. And also to update vaccines, right now I think this could be this week or maybe even maybe another week or so for new COVID boosters with an updated strain in them. It's an updated Omicron strain. And the only way that the manufacturers knew which strain to include was because of the sequencing that we and others do to know what's circulating. So in terms of influenza, Alana talked about NERCs. In her talk, I just wanted to emphasize that this is a very small subset of flu samples that we want. There's no way, unlike the PulseNet and the TB approach, where we actually try to sequence every single one of them, when in the peak of flu, it's like 30 or 40% of all tests come back positive. There's no way we're going to want all of those positives. And so it's a small subset that we ask for. Same thing for SARS-CoV-2. We don't want to ask for all of those. We did right before Delta happened, and we learned from our lesson there. We definitely never want to ask for all of them again. And I heard this phrase a little while ago, you don't need to count every raindrop to know that it's raining. So we take different surveillance approaches based on the main goals of our surveillance. Or the Wisconsin version of this, Cripes All Friday, you don't have to count all the snowflakes to know it's snowing, don't you know, from Charlie. In terms of another main aspect that we've used sequencing for is PulseNet. Just threw up a couple of numbers here. It's about 1,000 salmonella in Wisconsin each year that you all send to us, thank you, and that we sequence. It's about 400 Shiga-toxin E. coli and a handful of Shigella and Listeria. And then we've done a lot of increasing work and sequencing for antibiotic-resistant organisms, primarily on the bacterial side with carbapenem-resistant organisms, but we're also getting into Candida auris as well. And we can really hone in, use sequencing to determine exactly what the mechanism of resistance is for these carbapenemases. Is it KPC? Is it NDM? Is it KPC1? Is it NDM3? To have an overall idea of what's really most common out there, what's circulating. And again, that overall use of, are these isolates related or not? Is there an outbreak happening or not? And as an example, actually the previous example was from Italy, where they had an outbreak of carbapenem-resistant Acinetobacter baumannii. They only knew that it was an outbreak in that hospital because they sequenced it, and all of them were identical. And the Pseudomonas aeruginosa, which was a really good public health success this past year, it was really only figured out what was happening or what the exposure was because of sequencing was able to link all of those isolates from various states. So we did some whole genome sequencing of these Pseudomonas outbreaks or Pseudomonas samples. Other states did as well. They were found to be basically identical. So that allowed CDC to kind of look into the exposure of those particular people and find out over a lot of different questionnaires and looking into testing different different products that these people might have been exposed to that tracked it down to the artificial tears from a particular manufacturer, had that taken off the market, and then to stop the outbreak. So really good success that started with whole genome sequencing of these isolates. So additional uses that we have. There are quite a few. TB I mentioned before that we're getting into to predict that susceptibility testing. We're moving on a lot of cyclospora and cryptosporidium sequencing to identify clusters and outbreaks of this, both statewide and nationally. We're just about to go live with an enterovirus subtyping test and moving towards strep pneumo for our first CAP-CLIA test that we will result something out by next-gen sequencing. Currently all we're doing is under surveillance. And then hepatitis C virus, the GHOST project that Alana mentioned, and Candida auris as well. And then future projects, we are just adding more and more and more to this sequencing. Legionella, we used to do PFGE on clinical isolates and environmental isolates to determine if they're related. If the environmental isolate is related to the clinical isolate, that shows that particular facility is where the patient was exposed, and then mitigation measures can be put into place at that facility. We're also adding rabies typing, RSV surveillance, and norovirus surveillance in the not-so-distant future. So to get back to the rapid adoption of sequencing, name of the title. So we started sequencing in 2015 with influenza under the NERC and PulseNet. We've been doing that consistently throughout. Then 2018-19, we started doing more antibiotic-resistant pathogens, did a couple pilot studies with Hep C and TB, but then this little thing called SARS-CoV-2 happened, so we had to stop the Hep C and TB for a little while. Did a ton of SARS-CoV-2 sequencing. We're still sequencing for SARS-CoV-2. And then more recently, we've started adding a lot more of these: cyclo, crypto, strep pneumo, Candida auris, enterovirus, et cetera, et cetera, et cetera. We are really transitioning a lot of our surveillance testing more and more toward next-gen sequencing. And thankfully, we were able to use a lot of the COVID funding that supported SARS-CoV-2 sequencing for higher throughput instrumentation, more automation, more analysis, so that we can send more and more things down this sequencing pipeline. And I really want to mention again that all the surveillance and outbreak response work that we do is only possible because you all at the clinical labs send us samples and isolates that we ask for. So thank you very much. In terms of future of NGS testing, I think it's pretty clear we and other public health labs will continue to expand the use of NGS. It'll continue to become cheaper, more automated, and higher throughput. And I do think the clinical microbiology labs will do more sequencing as well. There's a potential that we're thinking about is to build a portal for that analysis, because I think one of the real bottlenecks for use is the data analysis side of things. It's possible to do the molecular testing. The library prep is pretty long, but it is a kit. And the sequencing, if you have the instrument, it's relatively straightforward. But that analysis can be really one of the bottlenecks. So we're thinking about having a portal for analysis. The clinical labs can send the raw data to us, get results back, and then as an extra bonus for us, we can have that de-identified data for our overall surveillance as well. And I do think that NGS will replace some clinical microtests, but definitely not all. And it'll really be driven by the cost and turnaround time. There are people and companies that are working on much faster sequencing and cheaper sequencing. They're not quite there for real programmatic use right now, a real rollout to a lot of clinical micro labs. But there could be a future where you have a Cepheid or a BioFire-like test where you put it in for extraction and library prep and sequencing and analysis. It could be possible. So hopefully that's been useful for you, and I'd like to have another poll here. So for future talks, we're doing a lot of this type of sequencing. We want to share the really good work, interesting work that we're doing that really is only possible because of the things that you guys submit to us. But we want to know exactly what level of talk. We don't want it to be too technical. We don't want it to be too simple. So A, B, C, simpler, similar, or more advanced level of this talk for future things. And we promise not to get to the level of 2020 difficulty or knitting with a cat. Okay, so we hit it mostly. There's a couple of you that would like more advanced. Sounds good. That's good to know. So with that, I'll say thanks, and I'll take questions on this part.
Any questions? Eric, do you want to use the...
Thanks, Al. That was great. I probably have a question that I should know the answer to, but when you're looking at relatedness for things like viruses or bacteria, or is there what's the cutoff in terms of what you consider related, and is it different for like viruses versus bacteria versus fungi versus whatever, TB?
Yeah, it's easy if something is 20,000 base pairs different, and it's easy if something is identical. Where it gets a little wishy-washy is if there are 5 SNPs, single nucleotide polymorphisms, that's where there's like 5 different bases different, or if there's 10, or if there's 20. There is no hard and fast cutoff. There's a couple different ways that we analyze things, and one of them is by a SNP matrix, so you see how many of all of them that you've looked at. Some are 0 apart, some are 20,000 apart, some are in that gray area in the middle. One of the important things for the outbreak analysis is to choose not just the ones that you're interested in, but looking at a known outgroup, so things that you know are not associated with it. Because if you have a very clonal MRSA, say, and if nationally everything looks within 10 base pairs, then if you look at a particular facility and say, oh, they're all within 10 base pairs, this is an outbreak, well, you don't have the larger context of it. So there's quite a bit of nuance to it, and there's a couple different ways that we analyze it. One is a SNP-based, one is a core genome-based, and in our reports we present both of those because they're kind of different ways to approach it, and kind of take it all together to make, if those two different ways of approaching it say the exact same thing or lead toward the very similar thing, then it's much more likely, yes, these are really related, or if they're very different, then they're very different. But yeah, there's a lot of gray area right in that middle. So good question.
Thanks.
And yes, it does vary by pathogen. Yeah, if you're talking about salmonella that has 5 million base pairs versus enterovirus, if you're looking at just a 400 base pair amplicon, that's very different in scale, and pathogens have different mutation rates also.
Yeah, I guess based on what you said, it would vary even between bacteria and bacteria, right? I mean, it's not necessarily the
Yep.
bacteria are this rate or whatever. Okay.
Yep.
Cool, thanks.
Yeah.
Any other questions this morning? All right. Well, thank you for that first wonderful talk on sequencing. And now he's going to switch on to his other cap this morning, and he's going to talk about the Auror's watch.
All right, and we'll do our best to get you to break by 10. Might be slightly late, but we'll always make it work, make the timing work. So this one will be about emerging pathogens and pathogens that we're watching for right now. So outline-wise, I'm going to start with a few useful resources that I use to track emerging infectious diseases, then do a very short history of them, and then talk about a bit of a quiz model for recent emerging diseases and outbreaks. And then at the very end, for this time, I'll plan to kind of put the two talks together and how people use sequencing to identify a new emerging pathogen. So useful resources, I would always start with ProMed. I use this daily. It is free. You can either go on the website or you can sign up for email updates. I probably get 5 or 10 emails a day, and they track many different things, both within the US as well as globally. Particularly for global emerging infectious diseases, this is my primary source. Tracking Ebola, Marburg, measles, other things globally, it is a really good source. So here's one just recently, last Friday, Nipah virus. There's a new Nipah virus outbreak in India, and this one is currently growing. There's 6 cases, but 1,000 contacts, and almost 300 that are at high risk. So this is one of the larger Nipah virus outbreaks in the past few years, and every single day there's some update on this particular outbreak. And it's not just humans either. So this one is from about a week ago, a pneumovirus at a dog animal shelter. And the typical format of this is they have the general source, which sometimes is a particular journal article, but sometimes it's just a news article in the media. And so they talk about what the actual outbreak is. And then at the very end, the really nice thing is the context provided by the moderator. So they have expert moderators. This one has the initials JH, and they give really good context to the outbreak. So if you're wondering what pneumoviruses are, what this particular outbreak is, and what they could do, vaccination or other reasons, other ways to control the outbreak. It's nice to put it in context. When there's a large ongoing outbreak like Ebola, they usually have 1 or 2 moderators that go from the beginning the whole way to the end and provide that context along the way of, oh, this is an expansion into a new area, this is worrying, or this looks like we're close to the end of the outbreak. It's nice for that context of things. Second thing I'll mention is CDC's MMWR, or Morbidity and Mortality Weekly Report. This is CDC's main way of getting information out pretty quickly. Here are a few of the articles just from the most recent week or two. And one thing that's really nice about the outbreaks that they have here, it's called the notes from the field. These are usually really pretty short, succinct summaries of outbreaks and what public health did to respond to them. And then one last thing that CDC also puts out is the Emerging Infectious Diseases Journal. The information isn't quite as immediate as ProMed Mail or sometimes as MWR, but they have really good in-depth articles, and they always have pretty interesting pictures on the cover also. So here are a few of the most recent articles in emerging infectious diseases. Klebsiella outbreak in South Africa that carries both NDM and OXA181 carbapenemase genes. Cyanobacterium diphtheriae emerging complex in Reunion Island, and a dengue outbreak response during COVID-19, where they talk about, because of the COVID-19 restrictions, how they changed their mitigation for the dengue outbreak. So brief history on emerging infectious diseases in general. There was an Institute of Medicine report back in 1992 that really coined the term. Before this, there was no term emerging infectious diseases. So this is where they defined it. And these are those whose incidence in humans has increased in the past 2 decades, or that threatens to increase in the near future. And it could be due to quite a few different things: a new agent, previously undetected agent, finding that an established disease that we already know about has an infectious origin, or the reappearance of an agent after the decline. And I think in 1992, with that last one, they were really thinking about TB, because TB in the previous decades before that really had a great decline. But then with the emergence of the HIV/AIDS crisis in the 80s, TB in New York City and elsewhere really took off again. So in response to this Institute of Medicine report, there was a CDC report called Addressing the Threats of These Emerging Infectious Diseases. And they laid out a few different real targets or things to plan for the future. And this is surveillance and response to these, applied research for the emerging infectious diseases, building up infrastructure and training, all with the idea of preventing and controlling these. And a lot of this is what we do at the state lab and what we partner with you on in clinical labs. And also around this time, there were a lot of discussions about the LRN, the Lab Response Network, where there are clinical labs who are the foundation, reference labs in the middle, that's like us at the state labs, and the national labs like CDC. And the whole idea with LRN is an integrated network of all of these labs to be able to prepare for and respond to bioterrorism, chemical terrorism, and other public health emergencies. So initially, a lot of the discussion was about bioterrorism, but then it was really realized pretty early on that all of the preparedness and response and building up the infrastructure really could be used for anything that was emerging, like emerging infectious diseases that were not bioterror agents. So this term of all hazards really came kind of bubbling up. A lot of people were talking about all hazards response. And in my mind, that's surveillance and outbreak response of whatever comes next. And as we've seen in the past 20 or more years, there's always something coming next, particularly the past few years with Mpox and SARS-CoV-2 and other things. So here's a little bit of a laundry list of things in the past 20 years. Some of them were brand new, like SARS-CoV-2 or the Elizabeth Kingia, kind of recognized as a brand new outbreak there. But then some of them we deal with all the time. Antibiotic resistance, foodborne outbreaks, those VPDs, and my favorite pathogen is flu, because there's just so many different flavors of it, and it's never boring. And that was really all of this discussion about emerging infectious diseases, LRN, all hazards preparedness. This is what really led to the Wisconsin Clinical Lab Network. Back in the 90s, there was a specific tuberculosis lab network in Wisconsin and a specific virology lab network. But to the broader all hazards network of connecting with clinical labs and public health, this is where the WCLN came from. And that is why we're here right now. So hopefully that provides a little bit of context on emerging infectious diseases and WCLN. And now get those clickers out, because we're going to have a little bit of a quiz here. So this particular one, we're going to start easy. Hopefully you got this one. This is the 2022 EPI curve, or epidemiologic curve. And an EPI curve is pretty simple. Basically, you chart the number of cases on the y-axis over time on the x-axis. This one goes up to about 600 at its peak. This particular pathogen the outbreak was not limited to the US, and it was previously a pretty rare disease. So which pathogen is this? Staph aureus, cowpox, mpox, influenza A, or not a pathogen? I'll give you a clue, it's not E. All right, almost everybody got it. This was indeed mpox. You listened to Alana's talk. This is the mpox case trends in 2022, and again, the y-axis, this is up to 600 at a particular day. This is 2023. Now we're down to 0 or 1 or maybe 2 in a given day in the entire country. So it's really, really nice to see that. We are much less stressed at the state lab being in this particular spot than we were last year, August, when it was 600. And I do want to point out this, end of last month, the CDC, Select Agent Program put out this SA-gram, they call it, to say that as of August 31st, CDC ended their public health response, thereby marking the conclusion of the outbreak as determined by CDC. And one thing that they changed here was that the reporting. So any of you who do mpox testing, there was this kind of grace period or ability to report all of your positives all at once in an efficient way, kind of a combined Form 4. Now they have stopped that as of October 30th. If you identify any mpox, you have to report individual Form 4s again. All right, next one. This is a vector-borne disease. It's common globally, particularly in Southeast Asia and Sub-Saharan Africa, and it's one of the big 3 infectious disease killers globally. The big 3 are HIV, TB, and this one. And the cases in the US are almost always travel-associated, except for this past summer, where there were 9 locally acquired or US-acquired cases. So which pathogen is this? Is it dengue, measles, Zika, malaria, or again, E, not a pathogen. All right. Hey, you guys listened to that too. Alana did mention that locally acquired malaria. Well done. So there was quite a bit of lay media news on this. This particular NPR article talks about one woman sharing her ordeal. There were also quite a few CDC communications that came out. So Florida identified 7 cases of locally acquired P. vivax. And actually Florida 20 years ago, 2003, had again a handful of locally acquired P. vivax, but none in the intervening years. Texas this past summer also identified 1 case of locally acquired P. vivax. But thankfully, there's no reports of local transmission in either of these states since mid-July. So hopefully those have been stopped. Another use of next generation sequencing, CDC took these samples, sequenced them, and found that all of the Florida cases were related genetically and not related from the Texas case, which really points to 2 different introductions into each state and then ongoing spread just this past summer within Florida. They also went back to the freezers and sequenced the ones from 20 years ago, and those were also unrelated to the current ones, which shows that that was a separate introduction 20 years ago. It would have been much more worrying if they were pretty closely related to the ones 20 years ago, because that would have suggested ongoing unknown transmission for over the past 20 years. And then also, most recently, August 18th, a single case of P. falciparum was reported in Maryland. I haven't heard too much more from this, so hopefully that's the only one in that particular region as well. All right, next one. This is an ancient disease that's been known for millennia. It's caused by AFB, an acid-fast bacteria, and there's pretty new recognition that it might be endemic in Florida. I'm sorry, not really trying to pick on Florida. They just have the most interesting stuff these days. So, which pathogen is this? It's an AFB, so it's probably a mycobacterium. Is it tuberculosis, M. avium, M. xenopi, M. leprae, or not a pathogen? A lot of people are pretty sure about this one. Okay, let's see. Got fast responses. All over the board. Alrighty, but 14 people got it right. This is M. leprae. This is leprosy. And this is a case report in the Emerging Infectious Disease Journal, just from this past year. And they talk a lot about the case report, but they also talk about the broader context as well. So since 2000 in Central Florida, they've accounted for most of the cases in Florida just in that particular region. 81% of the cases overall in Florida have been in Central Florida. And then more nationally, about 1/5 of the cases nationally have come from Central Florida. They also have had not just this particular case report, but other cases in Central Florida with no clear evidence of zoonotic exposures, so no evidence of contact with 9-banded armadillos, which we know do carry M. leprae, and that's a known risk factor, or travel to a particular area that is known to be leprosy endemic. This case report of lepromatous leprosy in Central Florida was particularly compelling because it was in a man who had never left Central Florida in his whole life. So obviously he couldn't have picked it up from anywhere else, and he had never seen an armadillo, so they said, okay, this could be potentially endemic here in Central Florida. And a little bit broader, 24% of new case patients in the US overall, not just in Florida, in these 5 years from 2015 to 2020, appeared to have locally acquired disease. So again, no other risk factors known. So it might be not just Central Florida, there might be particular other areas where leprosy is also endemic. All right, last one. This particular disease occurs after a tick bite from the Lone Star tick. It's becoming more common. I think there's upwards of 110,000 cases known to CDC, but it could be 4-fold higher. Symptoms can range from mild to severe. The mild ones generally is a hives and itchy rash, but the more severe ones can be quite severe with difficulty breathing and really big drops in blood pressure. And as of now, there's no treatment or cure. So which pathogen causes this illness? Is it measles, dengue, Rocky Mountain spotted fever, not a pathogen, or Heartland virus? All right, we got most looking for Rocky Mountain spotted fever and a couple Heartland virus. Let's see, who is the one person who said not a pathogen? You are right, sir. This is alpha-gal syndrome. It's a tick-borne immune reaction, and it's becoming increasingly more well known. It goes by a lot of different names: alpha-gal allergy, red meat allergy, or tick bite meat allergy. And it's called alpha-gal because that's a shortened version of galactose, alpha-1,3 galactose, which I really loved organic chemistry, so I had to throw up the structure of it there. It's a sugar molecule found in many, many mammals. So it's found in red meat, pork, beef, rabbit, lamb, venison, not in fish, reptiles, birds, or us. And the idea here is the tick bites a person and injects the alpha-gal that is in its saliva, and then in some people that can trigger an allergic reaction, which can be even further triggered by eating red meat. And often it's a delayed reaction where it's like 2 to 6 hours after eating red meat. So someone will go out to a big, nice steak dinner, then wake up in the middle of the night just sweating profusely and having these hives and itchy rash. And it's not that long ago, just 2009, that the real association with the Lone Star tick bites was made. So it's still, not everyone is aware of it, and many physicians are not aware of it either. And it's primarily associated with Lone Star tick bite in the US, but it could also be associated with other ticks as well. Because more globally, other countries, other ticks have been implicated. All right, we do have 5 minutes to go through this. Good. So I'm going to put the two talks together now: emerging infectious diseases and sequencing. And I'm not going to have a quiz here because I'm pretty sure just with this ProMed right here, you can probably tell what's happening. Undiagnosed pneumonia, December 30th of 2019, where patients of unknown cause of pneumonia in Wuhan were isolated in multiple different hospitals, but all their testing so far was negative. And I used ProMed to track this throughout the first month or two. So again, the next one here is January 5th, where SARS and MERS were ruled out. They had done those specific PCR tests, and they were negative for that. And then just 3 days later, they said official confirmation of a novel coronavirus on January 8th. How did they know that this was a new coronavirus? Next-gen sequencing. And it was 3 days after that, on January 11th, that the Chinese researchers that were a part of this made the genome publicly available. And I think this is the single most important thing that China did in the entire response, was to make the whole genome sequence available so that the rest of the world knew about it and could start making PCR tests. So I'll walk through exactly what they did using metagenomics to figure out what was causing this disease. So again, back to metagenomics, where you take a swab, or this might have been a lower respiratory tract specimen from these patients with pneumonia in Wuhan, and they sequenced everything that was in that sample. So they got a whole lot of human sample, a whole lot of human DNA, RNA, a whole lot of bacterial stuff, and then they got all of these reads from quite a few different patients. A lot of reads per specimen, and for each individual read, they used pretty high throughput computers and big databases to say, is this a human read? If it is, get rid of it, we don't care. Is this a known bacteria read, or a known, maybe it's an RSV or influenza read, get rid of that also. And then you say, what is left? What do we have that's left? And what can we do with all these reads that don't match anything, or that might match things only okay? Might sort of match other coronaviruses, but not really a great match for them. And then you say, from these reads, can we reconstruct this genome of this brand new thing that we haven't seen before? And I really like this particular chart because, so each one of these, so this yellow into purple, that's one read. And this green into blue is one read. And what you do with the computer sorting is you basically overlap all of them to be able to walk the whole way across the genome. And if you have enough of these reads that don't match anything else, if you have enough of these reads of the new virus, you can reconstruct the whole genome de novo, or from scratch, that you've never seen before. And that's exactly what they did, and then they reported it publicly. So once you have the full genome of a new virus, you can compare it to other known coronaviruses and make something that's called a phylogenetic tree here. And this is a relatedness tree of the particular brand new virus right here in orange compared to all the other coronaviruses that were known, or many of the other coronaviruses that were known at the time. Vertical distance means nothing in this tree. It's just a spacing so that you can actually read the names of them. It's the horizontal distance. And so these right here, all three of these, there's no horizontal distance in them. They're all completely identical. And so for example, horizontal distance, let's say, these are most closely related to these bat viruses, because it's the simplest way to explain it. It's the shortest amount you have to go, amount you have to walk from one virus to another is the shorter. The shorter distance means it's more closely related. So from this we can tell that of all the other known viruses in the world that we knew of, it's most closely related to bat coronaviruses. Suggests it could have originally come from a bat. We can also tell that this particular new virus that then went on to become SARS-CoV-2 is more closely related to SARS-CoV because it's kind of in this same sarbecovirus family than it is to MERS coronavirus, which is way over here, and you have to go a huge horizontal distance to get there. So you can tell some relatedness and guess some things based on looking at other viruses. And you can also then take multiple different SARS-CoV-2, line them up, and look for differences in them to identify new variants. And that's how that's how new variants were identified. But the really most important thing early on in the pandemic was posting this genome publicly so that the whole world could develop diagnostics, because it's way too expensive, way too slow to do this next-gen sequencing on everybody for diagnostic uses. But once you have that genome, you can align the new genome with all the other coronaviruses you have and look for unique sections within the new genome, because that's what you want to target for PCR, to make sure that it's sensitive and specific PCR. And with that, it's coffee time. I will take any questions if you have them. Thanks.
Thank you. That was great.
We got a
Any
question?
questions?
I can shout. So I find it interesting that of the outbreaks returning, the locally acquired Plasmodium vivax to outbreaks in Florida and Texas. Did you find any linkability or any reason due to mosquito migration? I'm just curious. Did you ever?
So is the question why there's locally acquired malaria? Introduction of that particular P. vivax, and there's mosquitoes in the area that are able to transmit it. I don't think there's anything new, or I don't think there's anything different about 2023 compared to 2022 or previous years. But there could be slow expansion of particular mosquitoes that can be vectors, and that could be something for the future that could really cause additional, more locally acquired cases.
And just out of curiosity, for the one single case of leprosy in Florida,
Mm-hmm.
relative to the rest of the, what is the current rate? Do you happen to know of leprosy in the world? And
So the current rate of leprosy in the world varies substantially by country. It really depends. And I'm sure that within particular countries it varies also. I guess I should also point out the rate of leprosy in the US is still very, very low. There hasn't been a large increase over time in that. It's still pretty low. But there is this new realization or thought that there is endemic areas of leprosy within the US.
Yeah, Al, I couldn't hear her question, so I might be repeating, but was it ever endemic in the U.S.?
That's a good question.
You know, like the malaria and,
I do not know if leprosy was ever endemic in the US. Alana, do you?
Yeah, absolutely. There was a leprosy care center down in the Florida area that still exists today, and it's a primary diagnostic location if you have a suspect patient. So they still exist. It used to be more of a sanatorium type location, but they're still a specialist in the country.
And we know, is our armadillos the reservoir, or is it just that experimentally that's where you can infect the foot pads, right, of the armadillos?
This is nearly impossible to grow in culture, so we're never going to detect a leprosy in our laboratory, for example, in culture, but it will grow inside of a 9-banded armadillo. So that's why they're Petri dishes for some researchers. So we know that it can grow in them, but we don't know if it's a reservoir.
We don't know if it's the reservoir. Okay,
Yeah.
but theoretically, where those things
Could
are,
be.
which I guess is in the southwest United States, Mexico,
Yep.
could be the host for leprosy.
It could be. We don't know for sure. We don't know where it was previously. It used to be endemic and seems to have gone away, but it looks like it's come back.
Yeah.
All right.
All right.
So, are there any other questions? All right. Well, thank you, Al, for 2 great talks. We really appreciate it. I'd like to take the minute now to introduce our guests today from the Wisconsin Department of Health Services. We have 2 of the experts in the hepatitis program that are here to talk with us today. So Caroline Mohr is going to be starting out, and she is going to be followed by Stephanie Borchardt. And they will be tag teaming to give you this presentation. We're pretty informal with with the introductions. That's the word I'm looking for, introductions. So please, you have the speaker bios in the folders, and I'll go through the folders in a little bit, but take a little bit more time to read about our speakers, and their contact information is in there, which is really important if you ever need to reach them. So with that, I will let Caroline get started.
Thanks, Erin. This thing is on. All right, cool. Haven't used a lot yet. All right, good morning, everybody. As Erin mentioned, my name is Caroline Mohr, and I am the Hepatitis C Surveillance Specialist at the Wisconsin Department of Health Services. But for today, I'll be your Quidditch coach as we review our best strategies for defeating viral hepatitis in Wisconsin. As Erin mentioned, I am joined by my fellow coach and Hepatitis B program coordinator, Stephanie Borchardt. I hope we have a couple Harry Potter fans in the crowd, so get ready for lots of Quidditch puns, y'all. Before we dive in, I would like to review the principles of Quidditch. Know your opponent. Understanding how different viral hepatitis infections manifest in the body is like knowing your opposing team's, strengths and weaknesses. Equally important is understanding the rules and guidelines around testing for different types of viral hepatitis. But the most important principle is to work as a team. With collaboration from the Wisconsin Clinical Laboratory Network, or WCLN, hospitals and health departments will capture the golden snitch. Our agenda for today is to discuss the testing and serology of the three main types of viral hepatitis we see in Wisconsin, which are represented by our chasers for hepatitis A, our beaters for hepatitis B, and our seekers for hep C. I told you there'd be a lot of Quidditch puns. I did not say they would all be good. Then we'll move into discussing some results from our viral hepatitis lab survey, an exciting new grant opportunity that we're working on, and how we can work together to eliminate viral hepatitis. Should leave us with some time for Q&A at the end as well. So without further ado, let's dive right into our playbook, shall we? So broadly speaking, hepatitis refers to liver inflammation. And for our purposes, that symptom is often caused by an infection with a viral hepatitis. So this chart up here goes through our best Quidditch plays or testing strategies for hepatitis A, B, and C, which we'll dig into each of these more throughout the presentation. So this flowchart goes through the testing and case classification for hepatitis A. And it uses a lot of other information besides hepatitis A antibody testing to determine if someone is a true case of hep A. And all this information is great, but it doesn't include the fact that many people are screened for hep A without any symptoms or an epidemiologic link to an outbreak. And according to the state's hepatitis A team, people should only be tested for hepatitis A if they have symptoms and think they might have been infected. This means all those pre-surgical and prenatal panels with hep A usually aren't necessary unless the patient has symptoms. And while it's not the end of the world to over-test for a condition, making strategic plays to save time and resources gives our team the advantage. This chart illustrates the typical serologic course of hepatitis A infection and recovery. So we can see anti-HAV IgM, which is the marker for recent hep A exposure, is detectable in the blood about 4 weeks after exposure. And anti-HAV IgG, which is the marker for previous hep A exposure or immunity, is detectable a few weeks after that. This chart shows that folks who are vaccinated against hep A will continue to test positive for HAV IgG or total anti-HAV. So screening everybody with a single total anti-HAV test isn't an effective way to identify hep A cases. However, without both the total and the anti-HAV IgM tests being run, oh, excuse me, I'm so sorry. I thought I saw something on the screen. So without both of those tests being run, we can't really get a super clear picture of a patient's Hep A status, so providers don't have the information that they need to correctly identify cases of hepatitis A. That's why we recommend a total anti-HAV test that automatically reflexes to an anti-HAV IgM test if the total is positive. All right, that was a lot of great information on Hep A, but we're going to need to fly in further if we want to beat viral hepatitis in this match. Get it? Beat for Hep B. That was really bad. I'm sorry. I will defer to my colleague Stephanie for this information.
Good morning, everyone. My name is Stephanie Borchardt. I'm an epidemiologist with the Wisconsin Immunization Program and also serve as one of two hepatitis B coordinators. Sarah Bourne, you may have spoken with her if you're from a health department. She is in the Milwaukee office and is happy to take questions on Hep B as well in the future. So without further ado, let's dive into Hep B. So wanted to highlight a few things that have changed with hepatitis B. One is that the hepatitis B recommendations for screening have changed. That was in March of 2023. So currently all adults should receive that triple panel screen, which includes a test for hepatitis B surface antigen, anti-HBs or hepatitis B surface antibody, and also anti-HBC or total core. And so they should be screened at least once in their lifetime. And the reasons being that infection can cause liver cancer. Also, everyone can benefit from knowing their status, given that that can change over the course of their lifetime. And then also that treatment is available in order to reduce viral load. This is a very busy figure, but it illustrates the progression from acute hepatitis B infection through recovery. So in newly infected persons, surface antigen is the only serologic marker that's detected during the first 3 to 5 weeks after infection. And it's good to know that surface antigen can be transiently positive among persons who've been vaccinated within the last 18 days. So sometimes we'll get a call from a health department and we'll have them check the Wisconsin Immunization Registry just to see if that patient has received Hep B containing vaccine in the prior 18 days, and they could be positive due to vaccination, which has no clinical significance. Also, the other serologic marker that I wanted to mention is the anti-HBC, and this appears at the onset of symptoms or liver test abnormalities, and that is one of the acute markers, but can be distinguished from IgM anti-HBC, and that IgM will be positive among acutely infected and will be that acute marker. Also wanted to mention that because the positive predictive value of that IgM test is low among asymptomatic persons, it's best to reserve that test for persons who are symptomatic or have an epi link to someone with Hep B infection. In persons who recover from their Hep B infection, surface antigen and DNA will clear from the blood, and the anti-HBs does appear as well as the anti-HBC, and those two tests will persist to be positive over someone's lifetime if they've recovered from that acute infection. And persons who remain chronically infected, the surface antigen and the DNA will remain positive. Again, those new screening recommendations were recently published in an MMWR. Just wanted you to be aware, again, triple panel screen is the recommendation going forward once in a person's lifetime. Pregnant persons should also have that triple panel screen. If you're familiar, usually pregnant persons are screened for hepatitis B surface antigen during every pregnancy. So you can go ahead and have providers be aware that they should replace that with a triple panel screen and can resume the single surface antigen testing or screening thereafter. So if you're noticing that particular health systems or providers are continuing to just order that surface antigen test, remind them that the triple panel screen is the new recommendation. And then also wanted to make you aware that the vaccination recommendations for hepatitis B have also changed. And they have changed from a risk-based vaccination strategy to more of a population-based strategy. So persons aged 18 to 59 are recommended to be vaccinated against hepatitis B, and persons 60 and older can also be vaccinated against hepatitis B. This is a very busy table, and by no means do I intend for you to be able to read it, but just wanted to show this to highlight the complexity of hepatitis B testing and interpretation of serologic results, and how having the triple panel screening results can be more value added for the provider as opposed to having a single surface antigen result to be able to interpret a person's status. Also just wanted to mention that the CSD position statement for hepatitis B, that language has been approved and is pending publication. It does align better with the hepatitis C case classification, so that will be coming out soon. It also expands the criteria for acute classification and allows for a DNA test to be confirmatory. So stay tuned for the publication of those updated guidelines. And before I pass it back to Caroline to talk about hepatitis C, I just wanted to put in 2 plugs. I know that some laboratories are able to report pregnancy flags. If your laboratory is capable of doing that, it would be so helpful to have that pregnancy flag for a Hep B infected or a person who's pregnant and also has a positive surface antigen result, so we can get them enrolled in case management. And the second piece, I know some labs are already doing this as well. If you have the capability of reporting all surface antigen and surface antibody results on children under the age of 5, that would also greatly help us to capture post-vaccination serologic testing results and would be able to pass that along to local health departments. So thank you so much, and I will pass it back to Caroline to talk about hepatitis C.
Thank you so much for that, Stephanie. That is a very good segue into something that we'll be talking about at the end of the Hep C section. So remember that pregnancy flag bit, y'all. But as we transition into discussing our final viral hepatitis for the day, you'll see that there are some similarities between Hep B and Hep C. The puns just keep getting worse. I apologize. Last one, I think, I promise. For example, both Hep B and C have recommended universal screening from the CDC. That means that all adults should be tested for hepatitis C at least once in their lifetime. Pregnant people should be tested at least once during each pregnancy, and folks with certain exposure factors should be tested routinely. And also, anybody who asks for Hep C testing should receive it. The CDC has also published this testing algorithm, which shows that the best way for us to identify every possible case of Hep C is to run a NAT or PCR confirmatory test on every sample that tests positive for hepatitis C antibodies. And this chart kind of illustrates why. It shows the typical serologic course for chronic Hep C infection. And we can see at about 55, 60, 70 days there, both Hep C RNA and antibodies will be detectable in a patient's blood indefinitely with some fluctuation. And although we could just use a hepatitis C RNA test to detect viremia post-exposure more quickly, we use these antibody tests to see if patients are mounting the appropriate immune response. Also, RNA tests are a little more expensive, and if we don't have to run them on every single person, we'd rather not. So, to optimize Hep C screening, providers should order a hepatitis C antibody test that automatically reflexes to a NAT or PCR test if that antibody test is positive. This also really streamlines things for patients as well, because instead of needing 2 different appointments and maybe 2 different blood draws to figure out what their hepatitis C status is, their provider can just order this single set at one appointment. Patient can get a single blood draw done, and bam, they know their Hep C status just from that one appointment. And as far as reporting goes, hospitals and labs are required to report positive Hep C antibody tests and all confirmatory test results, regardless of if they're positive or negative. And as Stephanie mentioned, there are some additional criteria that aren't required to be reported, but that really help our viral hepatitis teams out when it comes to case classification and things like that. Things like the results of liver function tests, knowing if a patient was jaundiced at the time of diagnosis, and knowing if a patient was pregnant. Again, we know not every lab routinely handles this type of data, but if it happens to be on your side of the Quidditch field, feel free to just fly it on over to us. Again, really helpful for case classification and for patient follow-up. All right, Quidditch players, we have done an excellent review of our best strategies to defeat viral hepatitis. So let's take a look at the score so far and dive into some results from our hepatitis lab survey. So with the State Lab of Hygiene, the HIV and hepatitis teams at the state conducted a survey to assess the completeness of electronic laboratory reporting, or ELR, among WCLN members. And we really hope that these results are going to be a resource to identify where we can support your testing and reporting efforts better. So looking at this first slide, we can see that the majority of respondents were from hospital systems, and that only a very small minority of respondents reported using something besides ELR to report their HIV or hepatitis lab results, which is great. Sidebar, if your lab would like to get started using ELR, or if you ever have any questions about it, please feel free to contact the WEDS team directly. They are a fabulous team for us to have on our Quidditch field. They are super helpful and knowledgeable. Lots of Ravenclaws on that team, so please feel free, reach out to them directly. Or if you want improvements made to ELR, they take criticism very well. Moving into some additional results, we asked respondents how often they reflexed to confirmatory testing on samples that tested positive for hepatitis C antibodies. And we saw that about half of them sent out for that kind of confirmatory testing to a reference lab. About 13% reported that they always automatically reflex to a confirmatory test on antibody-positive specimens, and then about another 20% said that they never reflexed or that they only reflex upon provider request. Seeing that about half of respondents sent out to a reference lab for confirmatory testing was reflected when we looked at Hep A, Hep B, and HIV test results. So we saw that reference labs are very highly utilized by the network. So our Hep C epidemiologist built a dashboard so we could really dig in and see which reference labs are being used the most often. And we can see that ACL, ARUP, and WDL make up more than half of the lab samples that are sent to reference labs. It's great to know that the WCLN has such strong relationships with these really large reference labs, because as we continue to improve viral hepatitis testing and results reporting, it's these strong relationships that are going to allow us to improve things across multiple sectors.
I'm sorry to interrupt. What's the left? What's FQ?
Federally qualified health centers is the FQHC on the leftmost column. And then WCLN is the Wisconsin Clinical Laboratory Network.
FQHC is?
Federally Qualified Health Centers. I apologize for any rebound. Yeah, of the lab results that we were seeing, we saw that's the type of reference labs that were being used.
Federally funded clinics.
In the state?
Yeah.
Yes.
Thank you.
Thank you for the clarification, Alana. Looking at some additional results, we asked respondents if they reported or sent their negative or non-detected hepatitis C lab results to local or state public health. And we saw about 45% said that they didn't report any of those non-reactive or negative results. We also saw a very large percentage of respondents putting in additional comments, like the fact that they send out to reference labs for their confirmatory testing. But when we asked respondents if they anticipated any barriers to reporting both positive and negative lab results for certain Hep B and C labs, some of them anticipated no barriers to reporting these results. And again, we see a lot of folks putting in additional comments, like the fact that they can't speak for their reference labs and whether they would be able to report those results back to us. But with the strength of the relationships between WCLN and their reference labs, we really think it's going to be possible for us to reach out to those reference labs directly and identify any barriers to reporting those results that they have in the future. So the WSLH and viral hepatitis lab survey really highlighted for us how crucial the WCLN is to improving not only viral hepatitis screening, but also complete and timely reporting of results. We just want to re-emphasize the CDC's recommended testing strategies for hepatitis A, B, and C to guide your conversations within your own labs, with your reference labs, with healthcare systems, because we know that those conversations and that work is going to bring us all closer to the golden snitch, which for our purposes is viral hepatitis elimination in Wisconsin. So the CDC has released several goals to eliminate viral hepatitis in the United States by 2030. These goals are to prevent new hepatitis infections and deaths, to increase the number of people who know their hepatitis status, and to ensure that every person living with hepatitis has healthcare and treatment free from stigma and discrimination. The WCLN is already doing a lot to make hepatitis elimination a reality in our state by continuing to advocate for those correct hepatitis screening panels and by coordinating the reporting of lab results across all of these different systems. Your work is making the detection of these diseases possible in our state. The WCLN has played an instrumental role in getting us closer to hepatitis C elimination, and we have the data to prove it. Of 350,930 RNA and genotype tests run between 2010 and 2023, we saw that about half of those went through a lab that's a part of this network, which is astounding. And although some of these lines look like Hep C testing has dropped a little bit recently, if we look at the overall trend lines, those dashed lines, we can see a significant increase in hepatitis C testing in the past decade. The WCLN's ability to expand testing capacity to support patients, providers, and health departments has made not only the detection of these diseases possible, but also the treatment of these individuals, which is, at the end of the day, what we want. You all really are our star Quidditch players in this match, and we could not do this work without you. So thank you so much. That being said, we would love your help further in continuing to spread the word about viral hepatitis elimination. Please feel free to let everyone in your networks know that viral hepatitis elimination in Wisconsin is happening. We're planning on it. We're thinking about it. And if y'all want to be more involved, if you want to have a say in what elimination looks like from a laboratorian's perspective, we want to hear you. We have elimination planning work groups that are being built at the state as we speak. So if that sounds like something you would be interested in, or if you'd like to give comment on our elimination plan, please feel free to reach out to us. We would love to hear your thoughts. We want to hear how we can better support you to make viral hepatitis elimination happen. Another really exciting opportunity to work with the WCLN is to work on this really cool grant to collect and analyze even more Hep C surveillance data. I think Dr. Sterkel probably mentioned it a little bit earlier today, but the State Lab of Hygiene and DHS are working to create this hepatitis C transmission detection network. So we can really identify those areas with high hepatitis C prevalence, see how they change over time, see if new areas emerge, so that we can direct our public health efforts better. And in order to assess the effectiveness of this system, we would love some help from y'all. So the State Lab of Hygiene is requesting samples from July 1st of 2023 to April 30th of next year for hepatitis C genomic sequencing. Again, if this sounds like something you would be interested in, please let Dr. Sterkel know. We can get you her contact info at the end of this presentation. This project is just one play to move us closer to that golden snitch, and we're really excited to work on this and other facets of viral hepatitis elimination with all of you in the future. And with that, I would like to thank you all for being a truly magical audience, and I would love to take any questions.
So recommendations with screening. We don't run much of this in-house being a small lab, but we get a lot of different things with recommendations from OSHA when it comes to significant exposures. They talk about using like the triple screens and that for B. I mean, is that those still recommended in those situations, especially with our source patients? Because OSHA just says run a surface antigen on your source.
Yeah, I will defer to Stephanie for hepatitis B, but I think generally speaking, if the patient hasn't been screened with a triple panel screen before, they should be screened with a triple panel screen. So if this is their first time being tested for Hep B, it should be that triple panel regardless of what the reasoning is.
And there are also some.
I'm going to encourage people to use the microphones. I'm sorry, we're recording, and we don't get good recording if we're not at the mic. So here, I'll
Sorry.
give you this mic.
I think I've got mine on.
You got yours on, but
Thank
okay,
you.
that's right.
With regard to that, there are some specific guidelines in, I think that there's a table in the pink book, that's the immunization guidelines, and then also in the red book. So there would be a nice table there for you on what tests to order for your source patient versus your exposed patient. But in general, as Caroline mentioned, it is good to have that baseline triple panel screen as well, and that might present a nice opportunity for the provider to order that.
As a follow-on to that question, what is the rationale again for the triple screen? Is it that it adds extra additional sensitivity to detecting positive active patients, or is it to just give the clinician a complete picture should the HBsAg be positive? I'm trying to understand, because yeah, that's what I grew up with HBsAg. So what is the rationale behind the triple screen?
Yeah, thanks for that question. So with having those 3 test results, it does give you a better picture of the person's status. For example, if they have just that positive surface antigen and positive total core, that would tell you that they're infected and infectious. If a person has a positive total core and surface antibody, that would tell you that they're immune as a result of previous infection. Sometimes over time, people do lose that positive surface antibody. So a lot of times we do see an isolated positive total core. And so that would also tell you that likely that patient is immune as a result of previous infection. If a person has a positive surface antibody and the other 2 tests are negative, then they're immune as a result of vaccination.
That was my next question.
Yep.
So it's the
Anti-HBs.
Anti-surface.
Yep.
Is
Antibody to
result
those.
of
Yep.
vaccination.
Thanks for that.
Thank you for that discussion. Go ahead, Eric, come up.
I just want to clarify one of the things you said about Hep C reporting. You said that positive serologies were reportable, and then positive and negative NAT results.
NAT and PCR, yes.
Would that be, I'm just thinking from our workflow, would you report negatives if they were there for like follow-up after being a known positive, or that's only during your, okay.
They're reportable in any context. In fact, we really love those, like negatives after treatment, because that tells us, hey, they sustained a virologic response to treatment, or they spontaneously cleared the infection. Also, on kind of a nerdy, crunchy side, it's really helpful for case classification for suspected reinfection. So you get a negative RNA test for Hep C, please send it to us. We would love that.
Thanks.
Yeah?
Yeah, so continuing on with HCV, what is the status of developing a vaccine, and is it really possible to reach your 2030 goal without a vaccine?
It's real tough without one, I won't lie. One of the difficulties with developing a hepatitis C vaccine, and again, this is more on the side of the, biochemical, brilliant people, and I'm surveillance, but one of the difficulties is because there are so many different genotypes of hepatitis C, and within each genotype, there's multiple other, differentiations. So it makes developing a vaccine against Hep C very difficult for it to be pan-genotypic across all the different types of hepatitis C that we have. In addition to the wonderful work of the WCLN, we'll also need to see a lot of additional investment in things like prevention and reducing the stigma of hepatitis C infection and getting education out about the fact that it can be cured. And before it can be cured, you really can prevent transmission at the individual level. But that requires a lot of additional resources for whatever those individual patient circumstances are. So we are hopeful, we are planning on it, we hope for the best, and we prepare for the worst in hepatitis. Great question, thank you.
Any other questions? All right, then thank you so much, Caroline and Stephanie.
Yes. All right, cool.
All right. And then our next speaker is a unique position within our State Lab of Hygiene, as Megan Lasure is an epidemiologist, and she's working with our AR network program. So she's our employee, but she also works with the epidemiologists very closely.
All right. Yeah, so thanks everyone for coming in. Glad to see you all here. So sadly, my talk is not as interestingly themed with the Harry Potter theme, but you'll have to suffer through. We're going to be talking about battling antimicrobial resistance. So these are the questions I'm hoping you may have, and I'll answer with this talk. So first, what's the AR Lab Network? What do we test at State Lab? And then what does antimicrobial resistance look like in Wisconsin? And then what's next for our program? So what's the AR Lab Network? Well, antimicrobial resistance is being increasingly recognized as a serious threat. We're looking at, this is from the AR Threats Report that CDC put out in 2019. And as of then, they were looking at about 3 million antibiotic-resistant infections per year, and several thousand deaths from these organisms. And so going all the way back to 2014, then President Obama signed an executive order establishing a task force for combating antibiotic-resistant bacteria. That their action plan came out the next year, and it suggested as a primary response to this to strengthen the national surveillance of MDROs. So surveillance of these organisms was pretty scattershot. Some states were doing a lot, some states weren't doing very much. And so they proposed the AR Lab Network to help fill in those gaps. The AR Lab Network was then established 2016, 2017 with 7 regional labs. And here is that map. So we are the Midwest Regional Lab. In addition to doing testing for the state of Wisconsin, we do some testing for Illinois, Indiana, Ohio, Michigan, and Kentucky, interestingly enough. And here are the pathogens that are tested by the AR Lab Network. So those first 4 are they consider the core testing. Those are done by all of the programs, and then the rest of them are done by 1 or 2 of the regional labs, sort of to cover the testing for the country. So first is carbapenem-resistant enterobacterales, or CRE, carbapenem-resistant Pseudomonas aeruginosa, CRPA, carbapenem-resistant Acinetobacter baumannii, which we call CRAB, and then Canada, including Candida auris, and that's the core testing, and then Wisconsin does some Streptococcus pneumoniae antibiotic-resistant testing. And so for those first 3, the carbapenem-resistant organisms, we are specifically looking for carbapenemase-producing organisms, CPOs. So carbapenomases are enzymes that these bacteria can have. They confer increased resistance to carbapenem antibiotics, which are considered drugs of last resort. And so if these are resistant to carbapenems, they tend to be resistant to other, especially beta-lactam antibiotics, but other antibiotics, and don't have as much treatment available. So the genes for these that encode these enzymes can be found on plasmids. Those are little circular, mobile genetic elements. They can move between bacteria and confer resistance. So in addition to looking for the spread of bacteria from patient to patient, we are looking for the spread of these genes from bacteria to bacteria within patients and between patients. And so tracking that spread of plasmids is CDC's really primary goal for CRE, CRPA, and CRAB surveillance. So what do we test at State Lab? We test bacterial and fungal isolates. The majority of our bacterial isolates are from Wisconsin labs. Some other state labs do send some bacterial isolates for confirmation and additional susceptibility testing. The majority of our fungal isolates, so the Candidas, are from other states. They send to us for confirmation of identification of Candida auris especially, and to test other species for antifungal resistance. So for CRE, we do bacterial identification with MALDI-TOF. We do an antibacterial susceptibility panel. It has about 20 drugs on it. That's the sense titer GN7F. We do a modified carbapenemase inactivation method, or MSIM phenotypic testing. That is to look for the presence of any carbapenemase activity. And then PCR testing for the specific carbapенemases on those positives. And we look for, these are kind of considered the big five carbapенemases, especially in CRE. So we have a KPC NDM, VIM, IMP, and OXA48. For Pseudomonas aeruginosa, the testing is pretty much the same, except for we only request isolates that are also non-susceptible to cefepime and or ceftazidime. At one point early on, CDC did a study looking at all of the Pseudomonas that we had tested with the AR lab network and established that those isolates that had carbapenemase were most likely to also be resistant or non-susceptible to these drugs. Pseudomonas aeruginosa in general has a lot of intrinsic resistance. If we asked labs to send us all of their resistant Pseudomonas, we would drown under the isolates they would send us, and they would be very mad at us for making us do that. So again, we just do the bacterial identification, we do the antibiotic susceptibility panel, the MSIM phenotypic testing, and then the PCR testing for carbapenemases. For carbapenem-resistant Acinetobacter baumannii, we do the bacterial identification and same susceptibility panel, but we can't do MSIM testing. It just doesn't work with Acinetobacter. We do the PCR testing on all of the isolates. We do the same five, looking for the same 5 genes, and then in addition, we have a panel of 3 different carbapenemase types, OXA23-like, OXA2440-like, and OXA58-like. These carbapenemases are kind of specific to crab. They don't really show up anywhere else. And most of our Acinetobacter is positive with one of these carbapenemases. And then we do testing for Candida, including Candida auris. We do species identification again with MALDI-TOF. We do an antifungal resistance panel. It's a custom sensititer panel that has triazoles and echinocandins by broth microdilution. There are not very many antifungal classes. There just aren't many options for treating fungal diseases, and so there are the 3 main antifungal classes, so the triazoles, echinocandins, and then amphotericin B, which we test by e-test. We are, kind of excitingly enough, looking into evaluating a new antifungal, which doesn't come along very often, Abrexafungerp. So we would be doing some testing, some antifungal susceptibility testing for that, and those results would really just go to CDC so that they can evaluate the sort of how this antifungal looks against the, what's out there. We also do some isolate retention for further characterization. For future whole genome projects, we are hoping to get testing for Candida auris whole genome sequencing on board pretty soon. Some additional susceptibility testing, like we may be doing for Abrexafungerp and other future projects. Some other states have wanted to bring on board some Candida testing of their own, and they ask us to send us their isolates sometimes. And then we do, like I said, that special project is us in Minnesota do testing for Streptococcus pneumoniae. So there are a couple different programs that do strep pneumo testing in Wisconsin. For AR Lab Network, we get isolates from about half of the country, and we do species identification, we do serotyping and serogrouping, and antimicrobial susceptibility testing. We ask for all CSF isolates, regardless of susceptibility, invasive isolates that are non-susceptible to clinically relevant antibiotics, and then possible failure of therapy or vaccine or outbreak isolates. And then we also have a special project going on right now where we are looking for carbapenemases in non-Baumannii Acinetobacter and non-aeruginosa Pseudomonas. So our testing has been really focused on those 2 species. They're the majority of sort of those in those genera, but we don't really understand the prevalence of carbapenemases in those other species. We have seen them before, and so we're asking for clinical labs to submit carbapenem-resistant isolates of either Acinetobacter species other than Acinetobacter baumannii, in addition to the normal Acinetobacter baumannii that you send, and then Pseudomonas species other than Pseudomonas aeruginosa. And we have a tentative endpoint on that project of December 2023, but it's kind of going to be up to CDC and how many isolates they get for testing. So that was all isolate testing. And then another big part of our testing at the AR Lab Network is colonization testing. So this is testing non-clinical swabs for the presence of MDROs. It's free of charge, including shipping and supplies. Most of these specimens are sent from the other Midwest states. This is the majority of what we do for those other states in the Midwest region. And it's also the majority of the volume of our AR Lab Network testing in the state. We do thousands of swabs every month, and the microbiologists are tired. And so you may ask why we are doing colonization testing. So colonization, it's the presence of these organisms without causing clinical illness. And MDROs, such as those carbapenemase-producing organisms or Candida auris, can colonize patients, and it seems like they can be colonized indefinitely. That's really concerning because colonized patients can transmit these MDROs to other patients and residents. They also often have high risk factors for illness transmission, so they can transmit it to other people. They can also become ill at some later date with these organisms that they are colonized with. These patients are often high acuity, immunocompromised, and live in congregate living settings. We have a couple different types of colonization testing. One type is a point prevalence screening of entire units or facilities. This can be either as prevention or response. We generally are deciding the scope of it with the facility. It's between us and the facility, and we're often testing dozens or even hundreds of patients at once. We can also do admission screening and focus on high-risk patients to facilities. So some of those risk factors would be healthcare exposure in other countries, contact with a known case, admission from a facility with known cases, or admission from a high-risk facility type, such as an LTAC or a ventilator-associated skilled nursing facility. So we have to show, sort of why we want to do this colonization screening, why we want to catch these cases as soon as possible. So this was a ventilator skilled nursing facility in another state, not in Wisconsin, fortunately. They screened this entire floor and found one Candida auris positive in March 2017. And then 10 months later, when they rescreened, unfortunately, they found many more cases. There's a prevalence of 43% on this floor. And so this makes, this is very bad for all of those residents. Candida auris is an organism that can colonize the skin. It can colonize the healthcare environment very easily. So it's very easy to transmit. It also is difficult to eliminate with normal cleaning practices. You need to use special cleaning equipment. And so, it can be, once it gets established in a facility, it can be very difficult to get rid of. And they also did CPO screening on that same unit at the same time as that second screen, and found that in addition to Candida auris, many of these patients had had carbapenemase-producing organisms that they were colonized with. You see some have Candida auris and KPC, KPC and NDM. Some of them have up to 3 MDROs. This, in addition to just making the cleaning difficult, in addition to be bad for the patients themselves, this is a nightmare if we want to cohort the patients, the residents, with people who have the same MDROs that they're colonized with, because you're going to involve a lot of moving people around, and that's very disruptive to them. And so we'd like to prevent this from happening in our state. So for colonization testing, for CRE and CRPA colonization testing, we generally use the Cepheid Gene Expert CARB-R assay tests. These are these tests for carbapenices directly from a rectal swab. So Enterobacterales is a genus that is often just normal flora living happily in our human gut. They're good organisms to have around in general. It's only when they escape our gut that they become a huge problem. So these are like Klebsiella, Enterobacter, even E. coli. And so it tests for these 5 carbapenemases directly from the rectal swab. Unfortunately, it doesn't really pick up many of the imp carbapenemases, but fortunately, we don't see a lot of that. We do reflex to culture for non-KPC positives, and then we also are validated to do culture-based testing from other specimen sources if need be. Here is the CRE colonization testing from 2019 to 2023. The red parts of the bar are those that were tested positive. So this is for the whole Midwest region, not just Wisconsin. But you can see on the y-axis, we are doing, hundreds, if not thousands, every quarter. Fortunately, this test, you can see this is a tiny version of the Cepheid gene expert that we have in our lab. We can test up to 16 of these swabs at once, and the results come back in about an hour. So this is fortunately a pretty quick test. Unfortunately, can't say the same about our crab colonization testing. This is culture-based testing, primarily from axilla groin swabs. So crab, like Candida auris, can colonize the skin of patients, and so we do an axilla groin, an armpit and groin swab. We grow that up in a broth that also has meropenem discs to eliminate anything that's susceptible. We subculture that to an Acinetobacter chrome agar with antibiotics, and then the identification is confirmed by MALDI-TOF, and we do PCR. Carbapenemase PCR is performed on those isolates that are crab. And we are also validated to test rectal and tracheostomy swabs with this same culture-based screening method. Here is the overview of our crab colonization testing. On the y-axis, we are doing 2,000 crab tests in a quarter. It's a huge burden on our lab. It's very, very useful, but it's also it's a lot of work. So I wanted to say that so that the lab gets the proper acknowledgement for how much work they are putting in for this. We also do a Candida auris colonization testing. We use a PCR detection of positives directly from the axilla groin swab. We have two methods for this. So the first method uses a Kingfisher flex extraction and then an ABI 7500 fast PCR testing. This is pretty versatile, and it has a lot of samples per run, 96 samples per run, so it's good for high volume days. Our other method is the BD Max, which has less hands-on time, so the extraction, amplification, and detection all happen on that same instrument. We're evaluating the use of the Panther Fusion to also give us more of a boost in how much we can test, because we are testing a lot of Candida auris swabs. So this is probably the majority of our testing. Something that also has been a shift is, when we started off, we were doing more point prevalence surveys, and now we are doing a lot more admission screening at some facilities all over the Midwest region. And so you may be wondering, I've mentioned that we're doing testing all over the region. What does antimicrobial resistance look like in Wisconsin? So fortunately for all of us, Wisconsin is a relatively low incidence state for these organisms. Our most common MDRO is crab, is an Acinetobacter. And we see seemingly stable levels of transmissions for most of these MDROs. Of note, Pseudomonas, Acinetobacter, and Candida auris were only made reportable in Wisconsin in mid-2022. And so all of the reporting before then was sort of just voluntary. And fortunately, we did detect a lot then, but I think we'll be getting a better picture of it in the next couple of years. And this chart is just new cases. So these are because these patients can be colonized with these organisms, we do see people pop up year after year, sometimes multiple times a year, but these are only new cases deduplicated. So we have been testing for CRE since 2010, since long before the AR lab network. We began with only KPC and then slowly added NDM and OXA48, and then when the AR lab network funding came around, we added IMP and VIM testing. These are isolates tested in Wisconsin. You can see we started off very low. We were testing a lot in the years before the pandemic, and then it dropped down. So that drop is actually not that bad. We had previously been requesting all isolates that were non-susceptible to carbapenems, so either resistant or intermediate susceptibility. We really did not detect any carbapenemases in those ones that were only intermediate, and so we switched to only requesting resistant isolates, and we think we're still catching all of the carbapenemases. So of those CREs that we were testing, the majority do not have any carbapentamases, but in 2022 we detected 45. Of the species we're seeing that we're testing, Klebsiella pneumoniae has the sort of the most carbapentamases in it. It's about a little under half of them do. We test the majority of what we test is like Enterobacter cloacae, but those aren't as commonly carbapenemase producing. And then we see a lot of E. coli. Those are sort of the big three of CRE. A lot of states only test those three, but we really look for any Enterobacterales, and so we have seen some carbapentamases in Citrobacter freundii, Providentia regerii, Serratia marcescens, Proteus mirabilis, Morganella morganii, and Klebsiella oxytoca. And so here's those species broken down, just the ones that were carbapenemase producing. As you can see, the majority are Klebsiella pneumoniae. Of the carbapentamases that are detected, most are KPC, that's a Klebsiella pneumoniae carbapenemase, that's what that stands for, and so understandably, it's the most common. We also see some NDM, some IMP, some OXA48, and then in 2022 we saw a couple dual mechanisms that were KPC and NDM. This is what that looks like across the state, so these are deduplicated cases. The majority of what we see, and these are raw numbers, not rates, but the majority of what we see are in the southeastern region. Understandably, it is where most of our people are. But we see some, in other regions of the state, especially IMP-producing carbapenemase organisms tend to be sort of scattered around the state. We really don't know where those come from. There's some hypotheses that they may be linked to agriculture or livestock, but that's a mystery for a later time. For carbapenem-reducing or resistant Acinetobacter baumannii, the majority of these isolates are carbapenemase positive, and the majority of them have OXA24/40 like carbapenemase. We also see some OXA23, but of the ones that we test, the vast majority have a carbapenemase. Again, this only became reportable in 2022, but we've seen more detection of it outside the southeastern region as time goes on. But the majority are still in the southeastern region. And unfortunately, among Acinetobacter, we do see some pan-resistant isolates. So those are non-susceptible to all of the antibiotics on our panel, again, which has about 20 antibiotics. So that's a lot to be resistant to. That's really not leaving much left for treatment. We're keeping an eye on that, and we are trying to make sure that we follow up on these cases carefully. So if most of the crabs are carbapenemase producing, fortunately, the Pseudomonas is the opposite. The vast majority of them do not have any carbapenemases. They are just resistant intrinsically or gain resistance, naturally through the course of treatment. We did see 5 of them, so 3 KPCs, a VIM, and then 1 that was PCR negative. We did a whole genome sequencing, and we found some sort of funky little oxas. And then Candida auris. So we were late to Candida auris. I think we were the last state in our region and the last state of the ones that we border to see it in a Wisconsin resident. But we did get our first case early 2022. These are all of the cases that we have seen as of when I made this presentation a couple weeks ago. And we had seen 11, so 6 clinical, 5 screening. So 3 of these cases had hospitalization in Illinois. 2 of them had hospitalizations abroad. I mentioned Illinois because in our region, that is sort of the Candida auris hotspot. These are cases as of end of 2022, and I believe these are only clinical cases, so there's more there. And what's next? So we are always looking to improve. We're looking to improve our testing. As I mentioned, we're hoping to bring on board Candida auris whole genome sequencing, which will provide clade information. There are 4 or 5 different Candida auris clades. Fortunately, the one we see the most in Illinois and in our region tends to be a less resistant clade. But we want to make sure it stays that way, and we'll also do some cluster analysis to hopefully let us know a little bit more about the transmission of these organisms. We are, like I said, going to evaluate Candida auris PCR in the Panther Fusion to increase our testing capacity. We have some ideas for improving our carbapenemase detection process. We're probably not going to do all of these, but we're kind of trying to figure out what would be the best. So there is a lateral flow test. I have a picture of it on the side. It's the Carba-5. It's kind of like the COVID at-home tests where you put a little, some little liquid in, and then it goes across, and it should not have all of the lines. That would mean it was positive for all 5. That'd be very bad. But it would, give you a positive for the different carbapenemases, which is kind of interesting. We also are looking to maybe multiplex our PCR assays. We currently have the KPC and NDM multiplexed in one, but maybe doing more of that, or using some strep kits. We are also planning to add a new AXA 235 PCR for our Acinetobacter, and then also evaluating testing for crab colonization directly from the swab instead of doing our culture-based colonization testing, which would save us a lot of time and effort. And part of what I am working on the epi side of things is I would like to really get more data back to the submitters, to you guys. We would like to maybe do a quarterly report to submitters. Some of the things we were thinking of including are how many isolates you submitted, what species were submitted, what carbapenemases were detected, and then either by submitter or as an overview of Wisconsin as a whole. And we want to know, if you could let me know what you would find most useful or interesting, please email me, chat me up at lunch. This is an example of sort of that I mocked up to kind of show what could look like potentially. We have, sort of how many isolates were tested across the top in the whole state, and then by region, carbapenemase is positive by region, and then sort of at the bottom some isolates by submitter. So, something like that. If that is interesting to you, feel free to let me know. Otherwise, thank you, and I'm happy to take any questions.
Thank you, Megan. That was great. Any questions for Megan? Please come up to the microphone.
When you say clinical cases of Candida auris, are these patients with confirmed infections due to Candida auris, or Candida auris isolated from clinical specimens where they may be not involved in the pathogenic process but are colonizing?
So the latter. These are those, so that they're isolates from a clinical source, basically not from a colonization swab. So we do have one facility in Wisconsin. Well, I think we're bringing in more, but at least one facility has been doing Candida auris colonization testing for admission testing going back a couple of years now. They're helped to detect some of these cases, and so, but if they're from a clinical site, then we come as clinical.
Is the AR network interested or tracking ESBLs at all? Back in 2010, we switched the breakpoints and stopped, looking for the ESBL confirmatory testing. But our infection prevention, I think they still need to report it to NHSN. They kind of use an algorithm. We get some conversations with our ID docs about, well, you've got these strains that, they're resistant to third generation cephsporin, susceptible to cefpime. Should you really treat? Should we be looking for ESBL? I think there's some papers out there now. What's with ESBLs?
I think it's been discussed. So the AR lab network, we're not currently doing any surveillance for ESBLs. I don't think they're going to bring it on. I know the EIP, the Emerging Infections Program through CDC, does population-based surveillance for ESBLs. And I think they might just sort of rely on that for their data. But yeah, I don't think that is in the plan to.
Yeah. Okay.
Any other questions? All right. Thank you, Megan. That was great. I appreciate it. The PACE code for the morning session of our regional meeting today here, that session code for the morning is 3761. And again, that PACE code for the morning session is 3761.